one slide.
Yeah.
Okay, I just started saying recording.
All right, we can go ahead and get started.
Okay, everyone. Sorry for all the technical difficulties, but we're here. We'll go ahead and get started with our panel. We have
Use them already.
Dr. I and
Oh, you
Dr.
know what?
Cramer.
I just need a case study.
Do y'all want to introduce yourself
Sure.
and your background?
Well, good morning, everybody. Thank you for being back here. My name is Dr. James Ikonomopoulos. For those who are on Zoom, because we're going to be recording this training, we'll be putting this on our Tex-CHIP website. And I am the Tex-CHIP program coordinator. And so Tex-CHIP is a program where we train our counseling students to work alongside other helping professionals and medical providers to learn how to work with integrated care services. So learning about the roles and responsibilities of other helping professionals. And today we're going to be talking about disruptive behavior disorders and how to work with youth and adolescents in particular that might have various behavioral health conditions. And we're going to talk about various diagnoses common to these conditions. And so we're going to start with a case study and a panel discussion, and then we're going to move on to our training. So we're very excited. And so that's a little bit about me, and I'll be also joining the panel discussion today. And then Dr. Cramer can introduce himself.
Perfect. Quick question. Do we have this on video as well or just audio?
It's actually
Yeah.
Just that screen,
recording
okay.
the screen.
Just so I don't need to look at anyone in particular. Cool. My name's Cam Cramer. I'm a psychologist and a behavior analyst and LPC and work here in the community. Currently operate a clinic called Student Psychological Associates. And we can talk further about that. Worked in a variety of settings, everything from correctional facilities, state agencies with intellectual disabilities, psychiatric hospitals. Yes, a variety of things, and then obviously private practice. So that's about me, and we'll talk further about me if we need to later.
Yeah.
For sure.
So we can go ahead and get started with our case study. This case study is about Raj. So 14-year-old Raj was brought to the clinic by his father. It was noticed that he entered the chambers rather reluctantly and plumped himself on a patient chair, his head bending down and sitting carelessly. His father started narrating about his son's conduct disorder. So a little bit about the family background. Raj is their only child who was born after 10 years of marriage. Parents underwent infertility treatment, and he was conceived in the second IVF cycle. Mother had endometriosis and hypothyroidism, while father did not have any major health conditions. During pregnancy, the mother had severe hyperemesis. Otherwise, all other parameters were within normal parameters. The child was born full term with help of elective C-section. Birth cry was immediate and weight was 2.5 kilograms. As per parents, his milestones were all normal and he had a healthy childhood except for mild colds occasionally. On closer questioning, they remembered that the child had a mild measles episode when he was about 10 months old and chickenpox when he was 3 years. They also said that from childhood, he was very obstinate. He would keep food in his mouth for hours together. Nobody could force him to complete it. If mother was missing for some time, he would wail loudly till she came in spite of other relatives trying to console him. In studies, he was good till class 3, when due to father's job, they shifted to another city. From that time, they have noticed changes in his behavior. So patient history, Raj lacked focus while studying. Classwork used to be incomplete. Teachers complained that he was disturbing other children in class. He would not inform parents about what happened in school. He would hide his exam answer sheets. Initially, they attributed the change in him to a new environment and thought he would overcome it. But instead, as his age increased, he became more aggressive. If his parents scolded him, he would shout back, show anger by banging on doors and crying loudly. He had poor sportsman spirit. If he lost in any game, he would throw tantrums and use abusive words. Father also said he liked expensive items. At the same time, he was affectionate, and if any friend needed his help, he would go out of the way to help him. He displayed emotions like jealousy and possessiveness, like wearing branded clothing and expensive gadgets. When inquired about his behavior at school, the father revealed that in school, he would often complain that other children are troubling him and would indulge in frequent fights with them. He would hide his answer sheets, report cards, would not inform parents of school activities, would take other children's belongings without asking, and academically was average. He likes music, especially fast beat songs and cricket. He had no known fears. In fact, he would tease and trouble stray dogs. He would take fancy to expensive looking gadgets, and few times parents noticed that there will be stuff in it which does not belong to him. But on inquiry, he would say someone has given it to him. He had the habit of lying smoothly that it was difficult for the parents to know if he was saying the truth or not. Remaining physical generals like appetite, thirst, bowels were within normal parameters. Dr. Reddy then interacted with the child. It was observed that on little provocation, he will become very agitated. He was almost ready to hit his father in anger in clinic chambers. So now we have our questions for the panel. Based on the information provided, what diagnosis would you give Raj?
You want to go
You
first?
tell me, I can do that.
Yeah, you can go first, that's fine.
So I think that there are probably a number of potential things that soft pop out of this. And I'll just kind of go through some of the signs and symptoms that probably actually answering like 1 and 2. First question is you do have questions. That's perfect. So what are the diagnoses, and then what are the symptoms that support that, if you will? I think initially, if you look into the patient history stuff, it starts to talk about lacking focus, not turning things in, having incompletion on assignments, distraction, typically disturbing others as fidgeting, or just not having that filter, which those things start to support the idea of ADHD. Obviously, when, at least in my opinion, arriving at a diagnosis takes more than just reading symptoms, right? You would need observation, you'd want some supporting data. But I'd say ADHD should be on your list, if you will. Some of the other signs and symptoms, perfect. Some of the other signs and symptoms, I was saying perfect for this, but some of the other signs and symptoms start to look towards oppositional defiant disorder. We have some pushback, some aggression, shouting back, anger, to the point that where it's interfering family functioning at the very least, and poor sportsmanship, tantrums. There's one statement in there that kind of throws me off. I felt like it was missing a word, that he is affectionate and would do everything, which you would suspect that would say just the opposite. But that's okay. Again, it's very unlikely in any real world situation that everything just falls perfectly in place, which is why we get to be trained to a level of competence and expertise that we can pick apart those things and look deeper. In addition to those, and I think my position would be from just diagnostically, sometimes ADHD can get to the point where if left unaddressed or unchecked, that can start to develop bad habits that look like ODD, right? And then we have to, from a conceptual position, discern, is this ADD and ADHD and bad habits, or is this truly something more attitudinal and ODD by nature? And then some of the other things that I would say, we start to hear some conduct disorder types of things, hurting animals, stealing things, taking things, lying, etc., as well as probably some potential emotional disturbance-oriented things. Sometimes things like what we used to call dysthymic disorder presents as a lot of irritability, related mood, pretty commonly associated with ODD when we're thinking treatment. Yeah, those would be my responses to numbers 1 and 2.
Thank you. I agree with everything you said. Now I would just also say, I agree, like initially, ADHD tends to be what kind of stands out with the lack of focus in school. And then we're noticing that he might be disruptive in class, exhibiting signs of hyperactivity, right? And then you start to see with that second paragraph, past patient history, beginning to talk about the oppositional defiant disorder symptoms. And then when you think about like how he's hurting, or teasing and troubling stray dogs, he has a habit of lying smoothly. He would take fancy and expensive looking gadgets. Then we're looking at signs of like a conduct disorder, right? And you would want to further assess for that to see like, does this person now like take advantage of others? Do they want to harm anybody? Do they lack remorse and empathy towards others? Then we're maybe looking at like a conduct disorder. Does he have any offenses? Has he been arrested before? But you also have to just make sure that they meet all the required criteria in the DSM-5 to be eligible for that. But another just diagnosis that I'd also want to check, maybe a differential diagnosis, would be disruptive mood dysregulation disorder. If they just kind of have this constant period of just always being irritable and frustrated and angry, and if that's the case, they would not have oppositional defiant disorder, because you can't have those two as co-occurring, but you could have a conduct disorder. So that would be the only thing I would look at, but I don't necessarily think he would meet criteria just based on the case study for disruptive mood dysregulation disorder. But it would be something to just kind of look at further. So
I like that, the notion of exclusion. If you have DMDD excluding OD, you can't have IED, but they do exclude the ODD. Yeah, so obviously more information, but to answer the question, cool.
So what assessment might you use in your session to support the diagnosis?
I'll let you lead.
All right.
I see that you've been doing a lot of assessment.
Yeah.
I've been reading that.
Oh, good. I like the Beck Youth Inventories because I think it really captures a lot of important areas for just overall functioning for youth and adolescents. So the Beck Youth Inventories assesses for anger, depression, anxiety, also conduct and related behavioral issues, as well as self-concept, which is kind of like self-esteem. And so I'd like to know kind of where he's at with his self-esteem and how he views himself in relation to maybe his peers. And then I'd also like to know where might he score related to depression and anxiety, right? Because we don't want to rule out or leave out any of those emotional symptoms as well. We want to treat and address those if that's present. And then with conduct and behavior related symptoms, like the questions on that scale is like, I steal, I get into trouble with others, I breaking up cars, houses, or other places. So it's real specific, and it would help us kind of know a little about his history and if that's maybe something that's going on with him as well. And then there's various ADHD scales. Like if he was younger, I might give like the Connor scales to his parents, the teacher. There's self-report scales. There's the BASC, behavior assessment scale for children. That's good to assess for behavior related symptoms. And then there's the RASI, which is the Reynolds Adolescent Adjustments. Forgot what its acronym is. Remember? Yeah, the RASI is a good scale that's also meant for assessing conduct and behavior related issues in adolescents. The Reynolds Adolescent Adjustment Scale, something like that. But it's a Reynolds scale for adolescents, and that one I think I find it useful. And then I like the Macy. It's a personality assessment. The Milan Adolescent Clinical Inventory, and that tells you more about some personality traits. With like traits, they're different than states, right? States are like, being in an emotional state that may not last very long after some time. and especially after an intervention or treatment, but a trait seems to be more enduring. And maybe there are some personality traits that might help explain too some of the behaviors that we see even early on, if we start to see certain traits that might relate to, conduct or antisocial personality traits even, then that might be, something to be concerned about and look further into and find appropriate interventions to handle that. So that's a little bit about assessments. Of course, I'd want to interview the family. I'd want to assess, the person individually, doing an interview, and kind of get a full array of things. And not just on needs, but also some strengths, what they like to do for fun. I'd assess some other positive aspects about Raj, and maybe identify protective factors that might, lead us into formulating good treatment plans.
I have to fully concur. I like all of that. I tend to try to. So there are tons of assessment scales out there, and one of our jobs is to ensure that we're competent in each of those scales. And so I tend to keep most of my assessments pretty similar and use the assessment tool outcomes and look at kind of a comparative analysis of the individual, almost sometimes even other individuals, if you will. I use the BASC regularly, almost for everyone under the age of 21. It is kind of a softer personality inventory, as Dr. I, it's gonna be hard for me. It alluded to, covers probably 16, 17 different dimensions, everything from ADHD, mood, behavior, adaptive, if you will. I like it because it works kind of for my system, because I click buttons and send it out, and they fill it out online, and I get it back really quick, and I can send it to parent, teacher, self. You can re-administer it over time without having to worry about any validity, reliability types of measures, or some gap, but different than like what you would see with IQ and achievement. So I like to do that, and that's kind of forms my foundational piece because it covers a lot of things. And then I use a number of symptom-specific tools. The Connors, as you alluded to, because it captures oppositional type of behaviors, emotional dysregulation, some of these other sorts of things, as well as has a secondary anxiety depression scale on the new Connors 4. I use the Children's Depression Inventory. I use the MASS, which is an anxiety scale, multimodal, multiphasic anxiety scale for children. A number of other unrelated scales that wouldn't really attribute to this. There are times that we don't always I don't always feel the need to do IQ and achievement testing in my practice, unless it's part of the referral question, or could be, right? So I don't always go in leading saying we're going to do everything. We're trying to answer the question, but in a case like this, if we are having trouble in school, you want to look at all the differential diagnosis, and so you would be looking at probably IQ and achievement. Is there something in the way that could contribute to so if you're doing a good IQ test, you can look within that and find out, is attention an issue? Do we have a limited tolerance for frustration when we approach harder, more difficult tasks? Is learning a new concept difficult? Because there are a lot of things that just you wouldn't typically do on a regular basis. That gives you a clean assessment of cognitive ability. And also achievement of, do we have some issues with learning? Is learning a concern when you compare IQ and achievement? And I think that's really important, because that could lead to frustration in the classroom, and then getting into other people's stuff, and disruption, and then you could be getting pressure from home to be doing well. But I also say that very often we approach kindergartners that are disruptive in the classroom, and they're understimulated, meaning that they're not getting enough, and we need to be promoting, a different kind of curriculum, more challenging, or even looking at GT types of programming, et cetera. So it's very dynamic assessment. And as Dr. I alluded to, you can go deep, and doing lots of observations, doing a lot of interviews. I sent a couple of students and staff this week out to a private school to do an assessment on a kiddo. And it's good to get out and see it. this doesn't do justice, but it's good for this exercise to be able to talk about all of those things. Yeah.
And I'm gonna, integrate questions 4 and 5. What treatment would you implement with Raj? And how would you include other professionals to provide treatment in an integrative approach?
Immediately.
Go ahead.
Cool. Okay. We'll go back and forth.
Okay.
That's match. So treatment, I guess the way that I think is that diagnosis drives treatment. And so we need to arrive at that answer firmly to really start to figure out where to go. But I'd say secondarily to that, orientation is going to drive treatment. And so to the extent that you have a strong orientation, that's going to play in. And then tertiarily, your lived experiences are going to drive your treatment, the way you think and what you've been through. So part of our job when we think about the assessment or the determination of treatment is we need to know where we are diagnostically, what our strengths are with respect to an orientation. And even if we're more, I'm not going to say integrative in nature, what seems to be more called for, recommended in that situation and or that diagnosis, but then also what you're comfortable with. What are you the right person to do treatment? As far as recommendations of things to be looking at in a case kind of broad like this, individual counseling would definitely come into place. Family counseling, having a school counselor involved, social work, it would be something obviously to consider. There may be the potential to have consultation with pediatrician and or psychiatrist. A lot of different things that could be this, as well as interacting with like coaches. I mean, this is obviously not a case from the United States, right? We see a lot of, we'll talk about this next, but it would make sense to be broad when you're contemplating what all could be done from a treatment perspective. I don't know that anyone ever gets to do everything that's broad. In a perfect world, we would be able to do all of those things. Those things can be very exhaustive, but in where you guys are, that's the way, in my opinion, we need to be thinking what all's out there, kind of like brainstorming parking lot issues, throwing everything up on the board so we can start to think, what are our possible lines to take, if you will.
Thank you. I'll speak a little bit from my experience working at a community mental health agency. And I've kind of carried this over into private practice work, but oftentimes in a setting that is integrated, like a community agency, like MHID, at youth services, somebody might be referred, like in Raj's case, it could be, a walk-in because maybe the parents referred them or, as a self-referral, or it could be because they're referred by the school, or it could be that maybe somebody's referred by juvenile probation, right? And so I'd like to kind of know too, what is a referral source, and then kind of where's like Raj's commitment to treatment? Is Raj wanting to participate? Is this something that he's like realized, like, yes, I go too far in doing certain things and I get in trouble and I want to change that? Or is this just like, I want people off my back, right? We talked a lot about assessment. We would do a pretty thorough intake, and then we would determine what level of care to put Raj in. And so there are various levels of care at a community agency, and the levels of care also determine the level of integrated care treatment. And so if he would be on like a low level of care, it would just be like really psychiatric services, and he would just be prescribed medications. And so he would also be assigned a case manager, and a case manager would assess various needs and strengths and make sure that also the family has, resources and supports to help Raj. They would formulate a treatment plan. They would then pull in a counselor that would be maybe a higher level of care. And then, so if I would be the counselor on this treatment team, I'd want to know what has the case manager sort of been thinking in their assessment. Case managers do a lot of assessing, planning, coordinating, and advocating, right? And linking them to resources. And so I'd like to know a little bit from the case manager, from their perspective. Are they also giving skills training? Skills training is a service that case managers give, which is more like psychoeducation, anger management, impulse control, communication skills. communication with like parents and teachers, problem solving skills. And there's various curriculums that they might be using. There's this one curriculum called aggression replacement training, and that's a pretty good evidence-based curriculum that's based off of CBT principles and actually applied behavioral analysis principles as well in that curriculum. So I'd like to know if he'd be getting skills training. And then from a counseling perspective, in a community agency, the recommended treatment is cognitive behavioral therapy for a lot of kids with disruptive behavior disorders, along with skills training, right? So I'd like to know too, what are some of his motivations for his behaviors? I'd like to help him understand the relationship between his thoughts, feelings, and actions. And does he recognize maybe with certain emotions he feels, what are the common thoughts he has? And does he recognize too, with some of the behaviors he engages in, his emotional state and also the thoughts and motivations behind it? Does he know the triggers? Does he know the antecedents that might lead to certain behaviors he engages in? And then does he have awareness of the consequences? Does he have awareness of what comes after he makes a certain behavior choice, right? So helping him learn to stop and think ahead. And that would coincide with the skills training that his case manager would give. So I would collaborate with the case manager. Then I'd also collaborate with the psychiatrist to see, is the psychiatrist aware of some of the behaviors that they're engaging in? And maybe, to see, does there need to be any changes in them, any medications? Does he still have trouble focusing? Does he still have trouble maybe with not sleeping well? And so I would share a lot of info with the psychiatrist, because at a community agency, you can go into the psychiatric sessions. You can have that discussion with the psychiatrist, talk about, how the medications might be working, and if they're taking their medications as prescribed, things like that. And so I would also want to collaborate with the school to see, like, is he receiving any special education or 504 accommodations? And with 504, are there behavioral accommodations being given for Raj at school? What's going on? What's the plan to kind of keep him focused in school, to help him succeed academically? And then, I might attend ARD meetings or 504 meetings if I'm given that privilege and opportunity. And I'd talk with, the school counselors, the educational diagnosticians, the teachers. I'd collaborate with them. Just to kind of, share my experience with Raj and working with the family. Maybe Raj is also involved in other services. Maybe the parents are getting services, like the parents can also participate in what's called multi-systemic therapy. And we have here in our community Liberty Resources that does multi-systemic therapy, which is kind of like a structural family therapy approach. So the MST program is a good resource as well. And going back to community agency work, oftentimes we have what's called a family partner, who is a parent that has a child or had a child in services where they were receiving mental health treatment. And as a parent, they know how to connect with other parents. And so I would probably link Raj's family to a family partner where they can get maybe support on the parent side of things. That's also what the MST therapist does. But I'd look to see if that is all coordinated, and I would collaborate with all those various helping professionals.
If I may, if I used to add to that, I love that, and I love all of those things. And you see how rich and overlapping services are in an agency that gets to do that. It's beautiful. I'd say something in addition is the use of a mentor. And you guys have done that on occasion pretty regularly, being able to not only just like the family partner for the parents, but also a mentor for the kid. That can be tremendously helpful. Someone that may have been there or done that, or just kind of big brothers, big sisters, with a lot of opportunities out there. And then even probably the last one of if the case rises to the level of intensity, we also have things in our community like CRCG meetings where the community resources all come together and sit at the table or nowadays using technology to discuss the cases. And that can be everything from CPS, law enforcement, probation, schools, therapists, MHID, all of these agencies, and just kind of a roundtable of where are we? What are we doing? What do we need? And thinking outside the box a little bit. I think that's important. Yeah.
And Dr. Graf just joined us on Zoom.
Oh,
cool.
fantastic.
So
Yes, I'm sorry for messing up, but I'm here now, so online though.
Let us
Um,
see if we can adjust your sound real quick.
Yeah, I'll just roll this cart over.
Oh,
by this
okay.
week.
All right.
Sorry. Oh, you have your drink. I apologize. Sorry about that.
Okay. So you
I
guys
know, I'm
are
sorry. I can move the laptop.
is it hard? Can you guys hear me at all?
Now we can. We are moving you closer to the students.
Okay. Okay. So you're in the
I don't know.
almost wrapping it up already, talking about the different professionals that can be involved. Um, that's where you're at now, number
We were talking about 4, 5, and 6 collectively. combined.
5 and 6. Okay. Well, you probably already went over talking to the pediatrician or the PCP in terms of screenings. I would have been also concerned about learning disability and ADHD based on some of his symptoms. And you probably talked about that. I hope so. The other one is more so involving indirectly other people through because of his symptoms of overactivity and anger control problems, whether or not to involve get him into sports. Well, lots of kids in our area, that's their way to channel their anger also and get recognition um, for physical attributes. So getting him into sports and finding if he's interested, as well as then having coaches in the school that are willing to work with him and help him with self-control. Um, I, I, I would be concerned about ADHD, mood disorders, substance abuse, and learning disabilities. So depending on if he had any of those symptoms, or that support more of those as primary diagnosis, then there would be referrals to psychiatry for medication treatment or substance abuse treatment if he's vaping excessively or other kinds of drug use. And then if he turns out to have a learning disability, to evaluate and get services for that in school, especially with like possible reading problems. So that, I mean, I'm leaving out what else I would have been taught prior to this, but that's kind of my step at this.
And to go along with treatment, what are some cultural considerations for treatment regarding Raj?
Well, there's a variety. First of all, it's not so clear where Raj is living, what country, what nation. Start out with a DSM-5, that's only valid for the US, and the rest of the world uses the ICD-11. So if you live somewhere else, we'll have to find get familiar with the diagnostic manual there. Then, so if he is an immigrant, what kind of level of acculturation does his family have in contrast to him as a factor of acculturation and complicating maybe communication within the family? Then, well, the case description kind of uses British terms and words, so you realize it's harder to imagine his life based on those terms. But we kind of assume our way of our culture here, which, for example, has lots of sports access, but other cultures like Europe or in India, they don't really have sports as part of the school. It's kind of outside of school. So that way of access of motivating him to participate to sports might not be accessible. Then there might be cultural specific to his, in that we have no idea of. For example, if they're of Indian descent, what caste do they belong to? What kind of expectations do they have? As for him, as goals for the future, and then also some cultures have very low acceptance of mental health problems, and there's a culture of shame associated with that. So how much is it acceptable within their culture to have a like depression or a mood disorder versus a conduct problem? So that might affect how willing they are to participate in the treatment if it's defined as a mental health issue. So that's my answer to that question.
Anything to
I
add?
defer to Dr. Iams.
Um,
I'm the left out one here.
no, I really like Dr. Graf's response. I would like to know, more so how Raj and his family may, feel about mental health treatment, if they, believe that it's something that could be helpful for them, or maybe they have attitudes and beliefs that feel like maybe they just have a different conceptualization of what help looks like, maybe they, are open, or maybe they're not open to receiving mental health treatment, maybe they have reservations about it, or maybe they may not know about it from maybe the types of services that we provide here in the United States, just depending on what culture and what country Raj is from. And then, do they make collective decisions as a culture, or how might they really feel like about like people visiting the home, so I would just take all that into consideration. And I put a lot of really, I would try to hold off on any assumptions, and I would really just try to let the family kind of share with me their experiences and just really how they understand maybe what's going on. Maybe they feel like some of these matters are best addressed within their culture, or maybe they feel that some of these matters are spiritual in nature. I'd like to ask them about that.
How would this impact how you're explaining a diagnosis to the family? How would culture impact that? Like, would you tell them the exact diagnosis, or would you be cautious with how you describe it to them?
I will let them know that that first of all, I want to be very sensitive to the family and to the culture, and I don't want to impose on them at all. And that the way we may conceptualize a client's issues and case is by symptoms, right? And so we may then look to see if we recognize certain patterns of symptoms, we then identify somebody maybe having a particular diagnosis. And I would just kind of explain the purpose and the role of a diagnosis for us. And it's really just to help recognize then appropriate treatment approaches and strategies for a collection of symptoms, for this pattern of symptoms. But I would be careful if they have reservations about diagnoses, if they feel like, hey, it's dangerous to give a diagnosis, I would be just careful and sensitive to that. And if it could do any kind of harm, I wouldn't give a diagnosis at all, because ethically we're allowed to withhold giving a diagnosis if we believe it could cause some kind of harm to a client. Our ACA Code of Ethics allows that. I'd also be sensitive to the kinds of assessments I'd be using, and if these assessments have been normed with populations that are representative of Raj and Raj's culture. And so those would be other, I guess, cultural considerations. And then of course, treatment that would be recommended for somebody from a particular cultural background, maybe like, treatments that are just more sensitive to somebody's culture. Narrative therapy tends to have a pretty good, and is well respected representatively in other cultures. because story and language is common to many people from amongst different cultures anyway. So I might think about maybe integrating narrative therapy into treatment. But I would probably have to do more research on different treatments for various people from different cultural backgrounds.
I want to say something real quick. I love that Dr. Graf brought up understanding, England, all of the possible India, possible locations one may originate, and even some of the subsects within such. I think it's really important not only to have that information and understand that you can't have all that information, right? There's no possible way to understand everyone's cultural identity, but to understand that there are also levels of assimilation or acculturation. So there are so many varying degrees of where someone is, and in that you can't have that breadth, that knowledge, right? That all of that information. We've got to be open. We've got to ask questions, and we've got to understand that we are entering into any interaction with a set of biases. And if you don't believe that you have those, then we're already making a mistake. We've got to try to be as transparent and hear so that we can get to where we need to get. I think that the question about diagnosis that's beautiful. We've got to try to be as transparent as possible and ask over time and multiple times to really even start to approach understanding. Even once you feel you have a good understanding, that's just when you just entered into a new sphere of possible questions and understanding opportunities, if you will. So the whole idea of multiculturalism and all these things, you will never arrive by design. You have to, that's really important to understand. Every step you take, you just see all of the new spheres to explore, and you just don't see all the stuff in front of you until you've taken those steps. So it is an eternal process, because cultures continue to evolve. So that's a big question, a deep question, and super important to understand.
Yeah, to follow up on that, it's also like if you don't ask, you won't know. So that applies to culture. Like assume you don't know, and then you'll ask more. But even about the diagnosis, if you don't ask if they have suicidal thoughts or if they see things that aren't there, or if they use drugs, you won't know. So that and that kind of goes back to the diagnosis component. What are the first 2 or 3 problems that really have to be addressed? Are the main problems? Are they more primarily behavioral control? Are they more mood control? Are they more so one part is a diagnostic code, the other one is more what's your treatment focus, and that kind of course has to be accepted as a valid goal for the family. So that's my slant at this.
One last quick comment. Also, Dr. I alluded to what their beliefs, their ideas on treatment, the referral sources. I mean, who's sending you here? Are you mandated? Is this probation? Is this pediatrician? Is this school? Because there can be a lot of resistance from not just a cultural perspective, but from any perspective, just where they are in life, if you will. Which I don't want to minimize. It's just culture, right? So it's why are we coming, and what degree of pressure is being put on dad or kid or both, and what were the conversations that you had in the car before you walked into the chambers? There's a whole lot that needs to be explored. Like Dr. Graf said, it's important to ask a lot of questions.
And what resources might be helpful for Raj?
Resources, I'm thinking, we kind of talked about this with just community partners, but I think of resources like we were saying, maybe supporting the family, right? And maybe linking them to like a family partner. With Raj, maybe there could be resources that the school can offer with like tutoring, or maybe just with the accommodations the school can give. And then, does the family need any financial assistance for anything? Maybe they qualify for some financial assistance, and so linking them to case managers, I might be able to assess for that further. Does the family or does Raj maybe need any resources to engage in any after-school programs or any youth groups? You know, like, so I'd look to see, are there any community events or community activities that might relate to Raj's interests? And I think that might help maybe give him, you know, maybe a new direction. And let's see, other things. Yeah, those are just some of the resources I think that come to mind, other than what we haven't already said.
Dr. Graf, do you have anything for this one?
Well, you know, like, change is difficult and motivators are the most important part for, you know, initiating or continuing to change. So the resource will depend also on his goals. What you know, what are the problems he's willing to work on to overcome. So so if it's more about reading, if it's more about then learning, then tutoring would be more important. Or if it's more about friendships and socializing, sports opportunities would be better for him, or maybe more explored if he's not thinking about that already. So I would, you know, go direct the resources also towards, or find the resources based on supporting the therapeutic alliance with him and the family.
And then I'm gonna combine questions 7 and 9. In your own profession, what personal example can you share regarding clients with symptoms of conduct and behavior related disorders? And what suggestions do you have for novice helping professionals to be mindful of Raj with conduct and behavior related disorders?
Well, then let me go first. So, and I work more so with younger children, but I mean, in our Hispanic culture here, there are those words like chiflado as an explanation for why kids act up or have behavior problems. And that's kind of part of that is the parents giving into their children when their children have demands on them, and the parents not being able to tolerate their child being upset or frustrated, and then they give in. And that is kind of like a setup for continued problems with demanding behaviors in the child and further giving in and behavior problems. So helping parents tolerate the upset feelings in their children without giving in, but helping them tolerate those emotions is kind of an important skill for the parents to learn and for the child to learn. So, and that's kind of the emotional aspect of learning compared to just defining it as a behavior problem. So that's one aspect. And for the novice helping professional, learning a certain approach under supervision through training is important to become more comfortable working with and more skilled at it. So I personally learn more about treatment approach that are more for autistic kids, like the floor time approach. But for the behavioral problems, I work more with the CPS model, or the collaborative problem solving approach. So I've enjoyed and I've benefited from my own training. Then, yeah, but for the behavioral problems, it's important to focus on the behaviors, but learning to work with the emotions involved is almost more important, depending on the case, kind of thing. So.
I'll go next. So I kind of alluded on this earlier on for novice professionals. The notion of when I pointed to the board, putting everything out there, right? To me, it's consider every single angle, every single opportunity, every single potential diagnosis, resource, community, opportunity, to be able to put as much out there before you start narrowing. It's like you want to look at everything and then slowly start to narrow as you continue to get more information and rule things out, if you will, right? So initially you want to be really broad and start to really tailor that. I think that's a good way of thinking for where you guys are. Similar to what Dr. Graf said, I like the idea of adopting an orientation that will drive some skills for you. My typical advice would be to find an orientation that closely approximate your natural tendencies, your innate personality, as opposed to trying to learn something entirely different. Because when you're in the room with someone, number one, especially if you're relatively new at this, if you're trying to be something totally different, you're not genuine. You're not who you are. And if you're doing that, you're not attending to all of the nonverbals, intricate things that, that even those of us that think we're good miss 75% of them in a given hour. If we're in our head thinking about all these technical things that we have to do, you're missing gobs of stuff, and that's the last thing we want to do. Arriving at an orientation, I guess there's different ways to do that. Think about, what kind of work do you want to do? Where are you comfortable? What brought you into this field? All of those things, because there are certain strategies, techniques, orientations that are more called for, more efficacious for different practice types and different populations and different presenting problems. I think that's really important. I'd say from my perspective, initially, I was really pretty behavioral. It was doing a lot of work when I was, I got my master's, I think, when I was like 23, and did a lot of work in behavioral oriented stuff. And then really adopted a lot of CBT oriented stuff. I went back to get my doctorate later on and chose a program that was very family systems oriented. So really evolved into this, cognitive behavioral therapy / family systems approach, which I thought was beautiful and loved it. And then was working for an agency, and they said, we're going, and it was an agency that got pressured to get a whole lot more behavioral in nature. And so we had a governmental entity come in and tell us, all your master's level psychologists are gonna be, BCBAs. And I didn't have to, but as a good role model, I did it. And it really I was already, I thought, pretty behavioral, but learning this, someone asked me the other day, like, how often do you use ABA? How often, do you use your BCBA, or how often do you bill for that? And I said, I've never billed as a BCBA. But I think that way every single minute of every day, no matter what I'm doing. I use that approach with so much of what I do, despite what problem I'm looking at. I'm thinking as a BCBA with depression, substance abuse, anxiety, ADHD, everything. So once you arrive at your first choice, I don't believe is typically where you're going to arrive. You're going to, again, evolve. You're gonna grow, you're gonna find an area that you really like to work in, but you have to start somewhere. If you're waiting for the best answer, you're gonna be just sitting there waiting. So make some decisions. You gotta start somewhere. The idea of CBT is great. I'm sure you can talk to a lot of those things. I want to bring up one quick case. Well, you know what? I'll present a case after you do.
Okay.
Go work.
I was gonna say that the advice I have for novice professionals, so I have found great success really just trying to build rapport with clients. You know, if I have all these ideas about like things I want to teach them or skills I want them to learn or ways I want them to understand their thinking, if they don't like me, they're not gonna want to do this. You know, they're not gonna want to listen to me. They're not gonna want to like just engage with me. So I really think it's very important to build rapport. And it's almost like by any means necessary, right? Like, so build rapport, it's very, very important. And that includes pouring in a lot of quality time into that person without judgment, just understanding, helping them also just kind of re-understand like the whole purpose of your relationship with them. They may have all these presuppositions and assumptions about what you're there to do. They may think you're just like my probation officer and you're just going to tell them what I did wrong today, right? So I even think like how I should dress. I try not to dress too professional because I don't want them to associate me that way. I'm just real casual. And I will try to use lingo, you know, I'm not as cool as I used to be, but I was a lot cooler when I was younger. But I could get along pretty well with a lot of, you know, adolescents and teenagers. I would play games. I would play chess, you know, and I would tie that into something that would be related, of course, to treatment, you know, where we're learning about how to stop and think about our choices, right? And problem solving, right? And so I'd leave some time for that in session that was beneficial for them because it would apply to what they want to do, you know. But I would just also find an opportunity if I had permission by their parents, you know, we would go to the park and maybe we would play a game of basketball or something because that was like something fun. And then it was a way to just kind of build rapport, you know? So it was something that was, I think, helpful and beneficial just to build rapport with your clients. And then from there, of course, you can begin to move into maybe having them share with you what they went through, sharing with you some of the trauma they may have been through. You know, I had just to kind of go into like an actual personal example, I had a client who many clients in this situation really, but this client in particular grew up in a single parent household with about 7 or 8 siblings in a very small home that's very old, rundown, and in a low socioeconomic area of the community, and a lot of community violence, gang activity, right? And he was sort of like considered like you know, he was considered the problem child more than anybody. And there were different dads for each kid, and they did not like his dad at all. And he resembled his dad a lot. And so he was picked on and he was criticized and he was sent away to live with an aunt, and to him he took that all in of being rejected. My mom doesn't love me, my mom doesn't care for me, my siblings don't love me, they don't care about me, why should I care about you all, why should I care about anybody, right? And that kind of became his mindset, that like if you don't like me then I don't like you. And he was that way initially meeting me, you know. And so I couldn't just go in and be like, we're going to do these activities today, I have these worksheets, or we're going to talk about like feelings. He's going to be like, get out of here. I don't want to talk to you. Like, I don't want to do any of this. This is stupid. Why am I here? Like, get off my back. But with just building rapport, having a good approach, having a good attitude, joking around with him, like, you know, letting him feel safe, and for him to feel safe to freely express himself, even some of the resentment and unresolved issues he might have with his family, just to hear that without judgment, I think did a lot for him to feel like he can now confide in me in some of these real personal issues, that now like he has someone to talk to and to kind of just release a lot of that stress. And then from there, the rapport continued to build. And then, he started really applying a lot of the principles that we would talk about in counseling. He would really be more thoughtful. He would stop and think about his choices and reflect back on things that we would talk about. And so all that came from the effort I put in to build rapport. And I think that was very successful for working with him and clients like him.
Dr. Cramer, you were gonna.
I could do that now, or I could do it as part of my presentation. You want to keep Dr. Graf? I mean, y'all just go.
Anything else you wanted to share, Dr. Graf?
I really like your example, but n- I mean, it's hard to start out and acknowledging and making mistakes, but to be able to empathize and for the patient or the client to feel like you understand them and what they're feeling, that's that takes a lot of intuitiveness and but also kind of willingness to not know. So and there's, I admire all of you for entering the profession when we need more providers. I'm very happy about that.
Thank you.
Thank you.
All right. It is 10:24. Why don't we go ahead and take like a 10-minute break, and then when we come back, Dr. Cramer will have our training set up for us. Thank you so much, Dr. Graf, for joining us. Really
Yeah,
appreciate
thank
it.
you.
Okay. Thank you for letting me in late.
Always.
Take care.
You
Good luck.
too. Oh, thank you.
So you know the strength of your, from over there.
I think so. Let's check it out.
Maybe we can stand a little bit. So.
Yeah.
All right, guys. Again, Cramer, psychologist, etc. We are going to talk about conduct, disruptive, behavior-related disorders. I have a big, long PowerPoint. But we're gonna probably switch some things up because I don't want to just lecture y'all for hours. I want it to be a little more interactive. That would be my preference. I feel like last time I did this, that I lectured and just you guys could get lecturing anywhere. And it just didn't feel like the best experience. So we're gonna try to do some things different and maybe wing some things and just kind of see where that goes. Are y'all good with that? Okay, cool. So I talked a little bit about me, about where I come from and what maybe helps inform my position on this. And so started off working here, or got my degrees here, finished my degrees, my bachelor's here, and then got my master's here in the other program. Worked a little bit for a psychologist and then decided I was going to go work for the Texas Commission, which is essentially jail for kids, right? So kids from like, I think the youngest we had across the state was maybe 10, up until they turn 21, at which time there's a decision, do you go to the Department of Corrections or not, TAMU-CC. And so got to be part of all of that and went out to West Texas State School, which is in the middle of nowhere, and worked out there for a couple of years, got to be part of the psychologist, the doctoral level psychologist who was there, was a little bit more sedentary and set in his ways. And so I got to do all the traveling to state office, to Austin, to Giddings, which is Capital Offender Program, and to Corsicana, which was our emotionally disturbed program. We got to be part of the treatment team development, the whole resocialization program. Got to do a lot of stuff when I was still really young and knew I needed to just sit back and listen, right? So it was really cool, good experience. And then I got a chance, they opened up I'm from Corpus, got a chance to move closer to home. There was a facility in the valley, actually in Edinburgh, that was at the time 24 beds, and they were expanding it to 256. So, and didn't have psychologists, so I took the position, and so I got to be the director of behavioral services there. Worked there for about two more years. So I had about 6 years at that point. And then kind of pivoted a little bit to come home. What used to be the Corpus Christi State School out here, it's an IDD population, was the state and that department was needing to expand their forensics units, which was a unit where individuals that are incompetent to stand trial needed to go. So they were all at Mahia, which is up by Waco, and they needed to expand, and Corpus got that bid, and so they started expanding that, and I jumped over and took that job. Now, before that, I came back, got married, had a kid, came back, worked for a couple of years, decided I needed to go get my doctorate. Went out to California, chose that program, worked out really well up in the Bay Area. Did that, then I went to San Diego, did my pre-doc year at it's the largest private psychiatric hospital in California, and so did that at Sharp Mesa Vista in San Diego, and then I came back to the Valley, worked for about another year, then that opened, and so then I transferred back up here and came to Corpus, and I haven't left yet. So I've made a lot of loops around the place, but got back here, worked there for a while, like I said earlier. Department of Justice came in because there were some deaths up in North Texas at a facility, and one in Austin, and so it's the first time that the Department of Justice has ever not come into a single facility, but to an entire agency. And so they brought all these best standards, and they were there quarterly assessing everything that they did. And at the time, they, think about services that needed to be delivered for individuals that had intellectual disabilities and or autism. It was ABA, right? It's only, if you go up to Massachusetts, we're in Florida, where most of these consultants were from, that's kind of cutting edge. And so they put that on me to convert my 18 master's level psychologists, that half of them were counselors and half of them master's level psychologists, but that was their term, to get this additional degree. And that's kind of just trickled into what I did. And then I left that left the state in 2013 and started private practice, me by myself, and then subletted a room from Robin Blue, who's a PCBA here in town, and then just kind of grew, and every year kind of added another person, and got to where we are now. Right now, I do a whole lot of assessment predominantly, with a variety of things. We get a lot of pediatrician referrals, adult ADHD stuff, do a little bit of maybe some juvenile oriented things, do some child custody stuff, try to stay out of court as much as I possibly can. Got a couple of cases, do some school evals, some FBAs and evaluations within the school district. So I'd like to think that although the big lockup kind of stuff isn't what I do on the regular basis anymore, there was a time when that's like all I did, it's really cool work. You learn a lot. You learn how much you don't know. You learn how much just because someone says it doesn't mean it, right? Because there's a lot of malingering. There's a lot of trying to ascertain what's the motive for that person. Why are they telling you that? And to look at all these things. And when you have individuals coming from all over the state, from all walks of life, some of these cultural things we talked about really come into play when you're throwing 24 kids in a pod that's all open, and you start to learn a lot about how people live, and even though there are rules and things that you're supposed to do and you have to do, sometimes it's like outside their scope of even understanding, depending on where they've originated and how they've been brought up. So a lot of different things. Let me, before we go too far, I want to know about you guys, so that I can make sure I want to know not only like obviously who you are, but where your sites are, and then what you want to hear about this, because I don't have to go by this per se, I'm gonna go by some of it, but I also want to give you guys what y'all need and what you came for, as opposed to just giving lectures. Who wants to start? We'll just start here and go there.
All right, yeah, so I'm Trevor Sorrells, you know me a little bit. But yeah, so I've worked in ABA for over 3.5 years. My primary site right now is at the Counseling Training Clinic here on campus. I've been there for 2 semesters now. I'm also with you and Joe Whitfield in Tex-CHIP, and I come from a biomed background. That's what I got my bachelor's in. And so I like working out of like narrative and act, but after, working in ABA for 3.5 years, I kind of have like some of that that behaviorist side in me. Yeah, I guess out of this, I have a client who has ADHD and their child has ADHD and conduct disorder. And I'm kind of curious on, I guess, kind of how to like pick up on that dynamic too, to see like, even if my client has like a little bit of like that, or like that oppositional defiant disorder as well. And that's what their child actually has too. So it's kind of stuff like that, kind of how that hereditary component actually. So.
Perfect.
Sure. Yeah, I'm from Canada. My name is Alicia Fuentes. My psych surgery school and the Children's Advocacy Center. I don't really have any questions. This open to you.
Checking the box, the Tex-CHIP box.
Yes.
Fair enough. Nothing's wrong with that either.
Distinctive counseling, private practice on Corona. And my Tex-CHIP site is the Bay Area Psychiatry Services. So we do group with with adolescents who often have some of the disorders that you're going to talk about. So I think what I want to get out of this training is kind of learning the balance between like giving trust and grace and leeway to young people, but also like having firm boundaries that so that they don't take over that grace. Because we've had a few issues where like, I don't want to be one of the adults added on to the adults that kind of look down upon them and punish them for their behavior, but at the same time, it's not safe and healthy for them to also walk over me. So yeah, just finding that balance.
Or safe and healthy for them sometimes, right? And a good example of someone like that would be like, okay, your teachers, your administrators, where someone's behavior is interrupting and disrupting other people's learning and their boundaries. And people in the position of having some of these disorders are like, that's all they're hearing from parents and teachers, and it just starts to get to the point where they tune it out. And so to find grace is a beautiful thing, right? To be forgiving, to take a different approach. I'd like to think that everyone started out with that approach, but if you don't get reception or responsiveness, it can quickly I see parents all the time that are just like, I just want to break. Nothing's working. And so to find ways to avoid burnout and to not take it personally or would be good things for you. And so to take care of yourself, working with a population like this, you got to figure out what are some good outlets and why am I really here? Because it can be very taxing. Really working with many populations can be taxing. But that's a whole nother topic, but we'll try to get some of that. Cool.
Hi, I'm Liliana. I work at a psychiatric hospital. I like adults. I'm not really interested in working with children or adolescents.
Cool.
But yeah, I'm interested in substance use too. So I think it's interesting. I would want to learn about like, I guess the onset, like when they start. And
This may be quite applicable to individuals. Like, okay, so what are the things that they experienced before they got to psychiatric? And Because substance abuse, deviant behaviors, a lot of those things, as one develops, we end up in some sort of facility, hopefully temporarily, sometimes not.
I'm Abby. I'm also at Bay Area Psychiatry with Tosin, so I agree with what she said. And like how to work with them effectively and get them to participate in group and like feel safe to be like vulnerable. And also like how these kind of disorders like come to be, like, is it trauma, hereditary, parenting, all that stuff.
That's a big question.
Oh.
The magic ball.
Yeah.
Okay. It's important because, and those are the questions we need to be asking is what led to this? What are the contributing variables? What are the things that contributed to this pattern of behavior, et cetera, so that, not just so that we know, but so we can be preventative and proactive in nature so that we can minimize incidents of that. Cool. Good.
I'm Melanie. I'm at the Active Medical Center. From this, I would like to know more resources available in Corpus. Because my site doesn't really have the resources and just like ability to provide like assessments, diagnosis, and so we usually look at referrals. And so I'd like to know more about what's in Corpus.
You said your site again was
Ecumenical. Ecumenical Center.
So I'm Clarissa. My sites are Ocean Behavioral Hospital and VA. So I use work with CPS. I don't have any like, but I know, yeah. So I use work with CPS, and like there is like this one case that really stuck out to me. She had a lot of behavioral issues, and of course, you see her brother and sister over. But in this one case, like, I mean, I don't remember right, but like you just see like the behavioral issues in school and family and everything like that. And, like they just gave her like a load of medication. And you just see the medication like just drastically in her mood. Like she was asleep at 6 p.m.
Okay.
And so to me, that's like interesting when you look at medication, but it would have been nice to see like how can counselors or like other things would have been definitely beneficial, you know.
When we talk about the everybody's just riding them. And then we resort to meds just to sedate them. We're not fixing anything. It's a temporary Band-Aid and you just haven't gone and taken a shower yet because then it's gonna be gone again. So we need to figure out what can we do. We need to figure out how to advocate to promote for less medication that does. I have no problem with medication that like just kind of slots someone, but not. Do you know what I mean? It's like, you're not allowed, you're not getting any work done. If you're, but you'll see those of you in psychiatric hospitals, long-term settings, you'll see that sometimes it gets to that point. And yeah, I think our job as humanistic beings, et cetera, should be in, helping professions needs to be to promote at least another attempt. One of the things I like to think about is that as a good example would be, okay, a kiddo that's just hearing all the time, or a parent, for instance, always trying to tell your kid something easy as, let's just say, okay, hang your towel up, right? I'll just throw the towel on the ground. You get to the point where it's like, hey dear, go hang your towel. Okay, you've said it 3 times. Let me then, let's go show you. The towel, hang it up, do this 3 or 4 times, and then you start to fade away. It's like, okay, go hang your towel up. And you get to the point where it's just like, stop taking the towels away from you. And so you get to that point, and one thing that we need to remember is the how towel hanger upper is developing, right? And in certain points in your development, it's like the window may be closed, right? You can't really see if the window is closed, but your communication's not getting through. And it gets frustrating, and you get to this point where your tone and your tolerance are just all falling apart. Well, one day that window may be open, right? Developmentally, that they may be able to hear it, but you're already screaming at them, and you're already like not having it. If that's what they hear when we first get to the point of them being receptive, the window being open, well, that's not a good start. That's not a good conceptualization. And I think that's the case with like over-medicated, with a lot of things, with parenting, a lot of different things where systems, individuals, families, systems etc., might not take the best developmentally accurate approach. And so sometimes we've got to shift those gears and run tests, run trials, like, okay, let's see if maybe lowering that dose may be more effective now, because now we're at a different, milieu that this individual's in, and they may be more receptive.
Hi, I'm Miranda. I don't have a site yet. I just came.
Cool.
I'm gonna be in practicum next semester. I am in the school counseling track and I taught for almost 10 years before that. So kind of coming to this with that mindset and seeing the shift within the system over the last decade with students that exhibit some of these behaviors. I'm also a parent to two small kids, so if I can get anything from that as well.
You're all that.
Yeah, no, for real. I'm like, yeah, the towel, the stuffed animal, the backpack, whatever it is.
Shoes.
Yeah, oh, the shoes. Yeah, so I'm kind of looking at it, even just as I plan on doing my LPC, but looking at it from a school counselor perspective and being that additional resource, kind of like how to kind of help within the system, be it their teachers or whatever, to make changes to adapt for students.
Gotcha. Okay. Perfect.
I'm Phoebe. I'm at the Counseling and Training Clinic and I am at Oceans IOP. I also used to work in the foster care system. I also saw a lot of kids who had a ton of diagnoses, a ton of medications, even when they were like very young. And to me, it was always difficult to pick out because these kids all had so much trauma. How do you know that this is a behavioral disorder and not a response to that?
Sure. And who's the informant?
Yeah.
To the prescriber, and that's typically a parent who's about done and or has multiple others, and that may not be entirely accurate, right? It's like I'm just not going around interviewing teachers. So I mean, how often do you get interviewed by a teacher? I mean, right? No, it's the foster parent that's saying, wow, this is what's going on. And okay, so that there are many cases where, yeah, it could be a trauma reaction, it could be tolerance, it could be just to an attempt to increase compliance, if you will. So a lot of different things that can play into that, for sure. It could be just the setting where they were, the dynamics. A lot of kids bounce around a lot from home to home to home, and what's the implication of that on their behavior? What, chicken or the egg, right? What did they learn from other individuals in that setting? What did they learn? Maybe not just trauma, but what sort of behaviors were modeled by the family of origin that eventually had to have their children removed. A lot of different things that go on with that. Okay, cool. So you guys have a breadth of, cool. We got a lot of ocean people. Right. They're serving y'all well, I guess. That's good. Okay, let me see how this is gonna work.
Have one here if you need.
Do you? Do you think it's just carry one around?
Yeah, the emergencies.
That's nice. It's the same thing.
Yeah.
You know what? That may be the problem.
I wonder, cause this goes up here, I wonder if this is yours, all right? It's like this one here.
Cool, thank you, sir. Okay, cool. So again, we're gonna kind of just do some, we may not follow this. I know we're not gonna follow this directly, but my original thinking was we were talking about some of the signs and symptoms associated with some of these disorders, as well as you guys what else, prevalence, causative agents, risk factors, kind of the outlook, prognosis. Talk about some general treatment options, the whole idea of parent training, and then ABA as strategies. Originally, when I was coming here, I was thinking, I want to touch on that, but I don't want to go crazy deep into that. I'd rather talk about a case and talk about maybe a couple cases and some real life application of some of these things. And then there's kind of based on one of the references, there's kind of an outline, if you will, about how to convert research into practice using some of these tools, and we'll quickly cover that. And if I need to email this to y'all, feel free, let me know. Cool. Okay, so these are some of my objectives. These may be different objectives than I wrote on my form that I filled out. But to be able to discuss or stay to discuss these disorders that we're going to talk about, as well as commonalities amongst programs. May not get, we'll see where we go. And use some parent training type framework. I want to, obviously, you guys have picked up on this. I have a little bit of a bias, right? I'm pretty behavioral in nature. I want to be challenged by y'all to be thinking of other things than just the way I think. Does that make sense? I think that's great for, number one, it's great for me, right? To stay fresh with that. But it's also great for you guys to be asking questions so that you guys all see that everyone thinks from a different perspective. It brings new things and different things into play. But again, very behavioral, you'll see. So some of the things we're going to talk about are some of these conduct and/or I took the disruptive part, behavior-related disorders, and some of the ones that we're going to talk about, ODD, IED, pyromania, kleptomania, to briefly, conduct disorder, and then to some extent antisocial personality disorder. They don't really have it listed in there, but that is the natural progression. Hopefully it doesn't have to progress to that, but it's worthy of covering, if you will. How many of you guys have worked with any people that have had these diagnoses? Cool. What age did you teach?
Elementary, so second through fourth primary.
Okay, cool. You guys heard a little bit about, my position on the idea that there can be some diagnosis that, if not addressed properly, can, I don't want to say morph, but they can add more. The patterns of behavior can grow, either naturally or by way of learning, and then meet criteria for other diagnoses, right? Sort of that behavioral evolution. This is a list of other, what I would say are behavioral related disorders, even though they're not listed in the DSM under that category. ADHD, OCD and those related, feeding and eating disorders, elimination disorders, sleep wake disorders, substance and addictive. But again, the way I think is, or was trained, is that everything's a behavior. Thought is a behavior. It's private that occurs. So I'm going to try to step out of that box. I'm not that strict with it, but behavior related disorders, we're going to focus more on the conduct related behavioral disorders. This is pretty tight. We all kind of, and you guys can look at this. We know what ODD is, right? It's this pattern of angry, irritable, argumentative, defiant types of behavior that lasts at least 6 months. You got to meet at least 4 of these symptoms. And angry and irritable, argumentative and defiant, some vindictiveness. Don't really want to go crazy into all the little notes. Do we all have a DSM? Do we all have the 5? Do we all have the TR? Good for y'all. I'm impressed. What's the difference between the 5 and the TR? Dun, dun, dun.
Year of publication.
No. Check. He's attentive. Good. What else? There's really one primary difference is they dropped the we're really just using ICD codes now. So typically when you go to make a diagnosis, if you're keeping with the current APA model, instead of for ADHD, instead of writing 314.01 or 00, it's really just F90 or 92 and 91 plus. So essentially all they've really done is drop the numbers that we have spent decades learning. They really complicated it for us, and now I have a book. So so ODD, we're pretty aware of that. You guys, many of y'all have worked with individuals with ODD, as is the case with I don't want to say any, but most of the diagnosis. You have all these signs and symptoms, right? The presence of those, but it has those signs and symptoms have to be impacting functioning or creating distress across a variety of situations or a variety of contexts. There's some exceptions there, but if you're trying to have a rule of thumb, signs and symptoms impacting social, personal, academic, etc., at least 2 or more areas. If it's just for someone to have oppositional behavior just with mom and dad, but then no problems at school, no problems with dad, no problems with coach, you don't get to really call that ODD. It's ODD-like, right? But we would approach that differently than a global, something that's crossing different contexts. We'd be working more with mom and the kid, as opposed to every environment. So disturbance creates distress, like I said, individual and others in immediate social context. It impacts social, educational, occupational, those sorts of functioning. Doesn't occur just during psychosis or psychotic episode or substance abuse and or some mood disorder, right? This is pervasive, if you will. And yes. Cool. So how many of you guys have ever worked with someone that has been diagnosed IED, intermittent explosive disorder? Yeah, I think so. Cool. This is something that when you think about, so to differentiate between like true IED and someone who may just have received IED. So there are many times where like Dr. Graf, Dr. I were talking about, like to do a real assessment, right? To do a good quality assessment, that is an exhaustive process. And to make sure that you are thorough and doing the best job possible, it takes time, it takes resources, it takes seeing someone multiple times in multiple arenas, context. You want to make sure you see the symptoms function or impacting them in all these areas. You want collateral information, all those things. Sometimes we don't have the luxury to do all those things. It's not that we don't want to, it's just their demands, right? And sometimes people end up with diagnosis that may not truly be accurate diagnosis. Does that make sense? That's always something to be cautious of when you're running into not just someone with a cognitive disorder, but any sort of disorder. Just because it's written and it was diagnosed before doesn't mean that it's going to be on your diagnosis or on your list, right? It still may be informative. They may have intermittent types or oppositional or IED types of tendencies, or it could have been state related versus trade related. It could have been the person interacting with them. A lot of things to go in. That's why we go in throwing everything on the board and start working our way, cutting things off. Fair? Okay, so going back to IED. With my toe. Recurrent behavior outbursts representing a failure to control aggressive impulses, which can include verbal aggression, temper tantrums, etc., and behavioral outbursts that includes damage or destruction of property, physical assault, etc. This aggression is grossly out of proportion with what would be expected given the situation and or the provocation. Let's see. They're not necessarily premeditated, right? If someone was premeditated, that would look more like, let's say someone's tantrums were like more by design. That would be looked more like ODD, right? Or even conduct disorder. This is almost like the burst. Just whoa, it doesn't line up with what just happened. These outbursts cause distress across areas of functioning. You have to be at least 6 years old. It says, or the equivalent developmental level. Yeah, I think I would just be sticking with 6. Does that make sense? Sometimes you can have some kids that are advanced. I'm just gonna skip that, yeah, because that's a whole other talk. The aggressive outbursts not better explained by some of these other issues, like Dr. I mentioned. If you have DMDD, you're not calling a part of it because DMD is a bigger umbrella, if you will. So are some of the mood disorders, personality disorders, etc. And then any other medical conditions, right? If someone's is having some issues with cognitive cognitive dysfunction, if you will, that may be a better example of IED, of what's not IED. Yeah. Cool. Pyromania. What is pyromania to y'all? What's the lay term for pyromania? What is a pyromaniac?
Like lighting shit on fire.
Lighting shit on fire. Yes. Right. Someone who sets fires. And why do they set fires? What are some ideas? There's no right answer.
I think it's fun.
Fun, right? To watch it because it could be for some trauma, it could be reliving something. There's no. Does anyone out here ever watch Criminal Minds? Raise your hand if you've watched Criminal Minds. How much have y'all watched Criminal Minds? I watched all of Criminal Minds. That's the coolest show ever. That kind of dates me, but if you watch shows like that, you see stuff like this all the time. And they've got this beautiful strategy that as one show ends, the other one starts right away. So you never get away. You're just stuck in this Criminal Minds loop. It's really intense. Do it for days. Pyromania is the deliberate and purposeful setting of fires, multiple occasions, right? It's not just an incident. This is where it happens again and again. In theory, so tension or affective arousal, then what that means is there's some sort of a trigger, an emotional trigger, whether it's stress-based or they're getting excited, and or it doesn't have any. I would argue that affective arousal doesn't have to be positive. It can be also negative, right? Arousal is an increase in that affective state. Before the act, fascination, or interest, curiosity, attraction to fire. The gain is pleasure, gratification, or relief when setting the fire or when witnessing a fire and or seeing the aftermath of that, some part of that process. Not really done for monetary gain, or as an expression of anything. Pyromania is really kind of interesting because it's right, it's super destructive, it's super dangerous. There's like people are relatively inhibited. No one's ever worked with pyromania, correct? I see kids not very often, but at least once or twice a year that will set fires, right? And or found a kid that was just randomly burning stuff in his room, making little fires, with papers from school, and this kid was like 6. And so initially mom was saying, wow, we've got a pyromania. I'm like, whoa, we're 6. Where's our supervision? What are some things we can do? Why do we have lighters in the house? Should we be putting these things up? And all those preventative things, right? Okay, yes, you need a lighter for the barbecue pit or a lighter for the candle, but your 6-year-old shouldn't be able to access it, right? Or put it in your car or do something with it, lock it up somewhere. So this happened, and inevitably the kid got a hold of every lighter that mom just left on the counter, but his mom was a smoker. To the point one day that because I talked to him and I never talked to him again for a while, and I think he had done it a couple times. He did it at a park, and then one day when he was maybe, I think he's 8 now, 9 now. His mom called me about a year ago. Actually came in, and he had been doing the same thing. None of the preventative, I wouldn't say that. It appeared as though none of the preventative, that right, that's a little assumptive of me, because she could have been doing all the preventative protective things. But he was on the ground in his room at the end of his bed, playing with the fire, and it caught his mattress or caught his bed sheet, which got to these things are supposed to be fireproof, right? Yeah, this little bed lit up, and the fire came, and so it went up the wall, and it was an older place. I think they lived in Section 8 housing, and so she got housing. Everything went wrong. From the kid, he wasn't pyromaniac, but when you think about what can lead to these sorts of things, something led to the repetitive engagement in just lighting little papers, tearing up notebook paper and lighting them up and just putting them up and burning them. And this progressive nature, I don't know, there's no way to predict where that's going, but it's progressing in nature, right? If all of supervision and all these other things that have been tried, I can't say I was an active part of that case, but that can be pretty scary when you think about what someone who has a fascination with fire can lead to. Fair? Cool. And this would be outside, pyromania would be outside of conduct disorder, not just a manic episode, not antisocial personality. Why would we think that would be the case? Why would they have that condition in there? Yeah, anyone?
Like, what do you mean, you have like under the umbrella of conduct disorder?
So these other disorders would be bigger, wouldn't they? Right? You could probably maybe put commentary in your report about this, or you could use treatments associated with pyromania. The reason these other ones are probably just bigger would better explain what would be going on. Kleptomania. We all know what this is, like stealing stuff, but it's a recurrent failure to resist impulses to steal objects that are not needed, not necessary. Who would be if you were thinking of a differential diagnosis, who would be most prone to be a kleptomaniac? What kind of person with diagnosis? Just look at that, read that top criteria.
ADHD.
Probably ADHD, right? If you're unable to resist impulses, that would be something you would be looking at. Increasing this, so an increased sense of tension immediately before committing the theft, which means they're stressed about it. They know they're doing something wrong, right? Is that idea of having this impulse and like looking around and maybe being slick and planning to do that, getting some pleasure, gratification, relief afterwards. It's not really vengeful, and again, the same sorts of caveats. And then conduct disorder. Conduct disorder is kind of where things, and there are a lot of things that can contribute to conduct disorder. How many of you guys have worked with individuals? Fair. Anyone else? Have you? Okay. What was that person like before we even jump into this? Gotcha. So juvenile justice, right? That's where most of that would be occurring. Because that's where y'all's program is, right?
Yeah.
You're doing stuff with Claudia.
Yeah. There's like one thing that was mentioned that stuck with me, like, I think he had said, just randomly, like, during the group session, he had said that, he has the same PO as his mom did, and that kind of like gave me context of like, yeah, you weren't given a chance.
That's big context. If your PO was your mom's PO, and it only takes 20 years to retire, and that means we had a kiddo probably pretty young, and not a whole lot of our environment changed, right? Probably living in the same neighborhood, probably living in the same house, probably all those variables. I'm sorry,
It was randomly brought up too. It had nothing to do with like what we were talking about during group. So I was like, that was really like weighing on him. And yeah, it was just kind of sad because it gave me a lot of insight into how like the conduct disorder kind of came about and how the environment really hasn't changed much. So yeah, it was just kind of heartbreaking because I was like, oh, you were kind of set up a way that brought you here.
and another word for setup would be not enough of the preventative factors were established, right? We'd like to think that would take on purpose, but if you didn't block it enough, you gotta do it on purpose.
There were no adults there that really cared.
Fair. Okay. So that's a whole emotional component of it. Fair. What was yours like?
Well, it's the same thing.
Same kid, that's fine. Why didn't you finish your sentence? No, what's your experience with this kiddo?
The first time I met him, we were doing a worksheet in group and he refused to do it and ripped it up and turned it into a blunt. And we talked about like decision-making stuff with them and he was just like, I don't care, I'll go back to juvie, like, I just don't care about myself, stuff like that.
He said no one cares, like, he had a sibling there too, and the sibling was like, you're gonna get in trouble, you're gonna end up like back in juvie, and he was like, I don't care, no one cares, my parents don't care about me, so what does it matter?
And he's like, I'm just a bad kid. Like, we try to do positive affirmations. He said, I have nothing positive to write about myself. Nobody has anything positive to say about me.
His windows, he's not even trying to hear the truth.
Yeah, I feel like the window was like slightly open in the beginning, but, like, there's other factors too, with like, intellectually, like, he's not, he hasn't hit like certain milestones, he can't read or write very well either, so, I know that causes a lot of frustration whenever we're doing group activities that like, he's not able to really participate with, and that's when the resistance and the, frustration with group like increase, and yeah, now I feel like we're completely shut.
Yeah.
And so there are a lot of variables that could be contributing to his oppositionalism, as well as the conduct, if you will, emotional stuff, self-esteem, knows we're academically lacking. This is as far as maybe anyone in my life has really ever gotten. Who knows? There's a lot of things that could be going on. We may not have a whole lot of positive role models, right? It's hard to look at your PO as a role model where you just keep getting in trouble. You know what I mean? It's like, oh, that would be, or your therapist or anyone, your teacher, your principal, they're sending you DAP every other day. Hard. Like, how do you break that cycle? Interesting. Do you guys work with the guys and girls? Cool, good, perfect. Maybe we'll talk about the young lady that's finally got out. Because was one of the things. Y'all had a girl there since October that just got out. How long have y'all been there?
I've been there since June.
Okay, cool.
I know we're talking about the same.
Fair, okay, we'll see. We'll save that when we talk about treatment and treatment amenability. So conduct disorder is a repetitive and persistent pattern of behavior where the basic rights of others are made or social norms are violated and consistently. There's aggression to, I'm not getting all like specific numbers and everything and criteria, but aggression, bullying, threatening, intimidating, fighting, using weapons, being cruel, people, animals, stealing, coercive sex, destruction of property, which can include fire setting, deceitfulness or theft, which can include stealing, and things of that nature, lying, serious violations of rules, etc. Truant before 13. Why would that say before the age of 13? Is it developmentally appropriate to start skipping after 13? I think it is too. I saw that and had to bring that up. You got a teacher in here. Good. Okay. Obviously, again, as the case with a lot of different things, having significant impairment across settings, right? That's a big relevant component. And the criteria for antisocial personality disorder is not met because that would be, doesn't have to be, but would be the next evolution, right? And then there's onset, childhood, adolescent, or unspecified if you don't have that information, and all of these different conditions, which are relatively, they're helpful as far as coming up with treatment strategies, but not necessarily for today. Severity, onset, if you will, can be so this kind of talks about the progression, if you will, the common progression, because there could be a variety of different things that could go on, especially when we start talking about trauma and some of these other things, or removal and placement. But typically preschool years can be kind of the onset with ODD, which can progress. Things that happen in middle school or adolescence, that's when we typically see it. There's a big rejection of pro-social peers and associations with delinquent peers, and those are some of the things, reference and stuff. The amount of the percentage kind of prevalence of conduct disorder, typically with most stuff ranges from, in most research and data, from 2 to 10%. I'd say most commonly it's going to be about 4%. Or the Theravive says that it is more commonly in boys than in girls. And then some of the impact of that. Okay, one button at a time. Okay, what are some things that contribute to some of these disorders? That was one of the questions. Like what leads to this so that we can be informed about what to do? And conduct disorder, I'm gonna talk about conduct disorder generally, right? Since that's kind of one of our bigger umbrellas, as opposed to every little other one. Brain damage can obviously, right? That can have anything going on internally. Traumatic event, there can be a genetic predisposition. Obviously, environments, just as if not, I believe the environment's probably a larger influence, but child abuse, school failure, social problems, etc. How many kids do you guys know that experience one or more of these? I mean, they're everywhere, right? Does that mean everyone? Why? Why does not everyone? Why is it limited to like 4% of the people that have these things comes out to not have conduct disorder, or 4% do? Intervention, support, right? What else?
How many of the factors are interacting
Okay.
together?
Right, okay, the conglomeration of those factors, sure. Synergy. Well, I like to think of synergy as being have a positive connotation, but in this case, okay, so yeah, it can be a variety of different things. Some kids with some individuals, there's been associations with frontal lobe damage. Obviously, we said that already. The ability to plan, stay away from harm, to learn from experiences. But we also have parents tell us all the time, like, you know, gosh, she does the same thing over and over and over and over. Your two goes this way. They're still writing twos and S's backwards. There's a lot of other things that could explain what would be going on with that. We're just trying to narrow this. Traumatic experiences, for sure, can lead to depressed moods, behavior problems, the wrong crowd, substance abuse, all of these sorts of things that start us down this path, if you will. We talked about, I said earlier, it's more common boys and girls. But you'll see a lot of research that talks about those individuals, and y'all's individual in particular, that are disadvantaged, come from homes that lack means, that are dysfunctional or disorganized, right? And so that would be what are populations, et cetera, that would maybe, based on these factors, have an increased probability of having someone with conduct disorder? What are some things y'all think? What comes to your mind? Low S, yes, could be, sure. Also, yes, of course, good. What else?
Like instability at home, like caregivers and stuff, people kind of coming and going.
And or mental health, mental illness, right? What else? So yeah, think about not knowing where you're gonna be. You know, you have a birthday coming in next week, and not knowing where your birthday is your birthday gonna happen? Which family am I gonna be with? That could quickly lead to some frustration and an epic attitude, right? Real quick. Yeah, also similar homelessness, not knowing what's going on. You know, this whole pattern of getting to conduct disorder can come out of necessity. I don't have a place to stay. I don't have food, and it's my turn to go get food and steal. And that one thing leads to another, and you know, now they're talking to me and telling me this, and I get locked up, and boom, 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 right? That could very well be easy, and they probably didn't have any of those other previous criteria, right? That would be kind of an anomaly, but we could see that could happen, right? Those are the cases that we like to think, oh, I just got to intervene right here at this point to stop that. Whereas some of these are more difficult. People that have the comorbidities, mood disorders, anxiety, PTSD, substance abuse, ADHD, learning problems, all of those things like Dr. Graf was talking about. All of those things can lead to scenarios that someone stops caring, doesn't believe they can, or they have the ability or the support. And then they start telling themselves they don't have the desire to even try. Why should I? No one else in my family ever graduated from high school or ever got a job. And, you know, being locked up is not that bad. At least they take care of you and they feed you. Which, if you're comparing that to being homeless, that could be a rational argument, right? So to me, I think it's really important to realize that just because someone has met this criteria and or has the diagnosis, y'all's job is to still humanize them, right? To not, don't ever let a diagnosis, our diagnosis essentially is designed to be a shortcut. It explains a category, a set of behaviors that happens so that we know what we're talking about. We can have, it's an objective, designed to be almost like be an objective term that lets us think the same when we're talking about treatment, if you will. Does that make sense? Does it serve a great purpose? It definitely helps a lot, right? Could we have similar conversations without having a diagnosis? Of course, it may just take longer for us to further objectify. These sorts of behavioral disorders, just because someone has one, if we treat them as if they are their disorder, we're not going to get very far. In part because some of these disorders are based from people treating them that way, right? That can be a driving force. If someone's, always no, and the door's always closed and no one can ever do, the only way to get someone's attention is where your behavior escalates to a point of necessity, you've started down the path. And if the path continues to reinforce more of that, that's what's going to keep happening. So it's really pretty important to be cognizant when you guys are coming in to change things. All right, we need to be looking at self-esteem. We look at all of these other things. There are some, instances and discussions about temperament, etc. You can't even read this. I'll read it to you real quick. Its summary is there are genetic or biological factors that testosterone levels, traumatic brain injury, seizures, those can all increase the propensity for aggression. So you can also have parental, familial, and or environmental factors. Parents of adolescents also have kiddos engaged in substance abuse, antisocial behaviors, home environment, exposure to domestic violence, so low social and economical environments, overcrowding, underemployment, unemployment, access and availability of drugs, crime in their neighborhood, etc. All of those things can contribute to the diagnosis of conduct disorder, behavioral types of things. That says the same thing differently. What is the outlook and prognosis for these things? Depending on how early, so the earlier that someone arrives, if you will, the more difficult it is, the longer they're in it. Does that make sense? The more that you start to experience some of the insulating variables, which can be reinforcement, punishment, etc., that help establish these behavioral tendencies, if you will. The longer you're in that, the harder it is to break away from it in most cases. Sometimes I can argue that I've seen people that have been in it so long that they become tired of it and they're ready for a change. They're like, I'm done with the game. Like, is this like, just sudden maturity of it? Sometimes it is. Sometimes it's like seeing someone else that took a different route. I mean, there are a lot of different things that can change someone. But the longer you're in it, the harder it's gonna be. And the earlier it starts, the harder it's gonna be. The disruptive behaviors and conduct stop during early adulthood. In about a third of the cases, they're probably going to continue. Many of these cases meet the criteria for antisocial personality disorder. What else? Early onset of the condition before the age of 10, which wouldn't start with conduct disorder necessarily. It could. is associated with a poor prognosis and strongly associated with significant decline in school performance. Well, yeah, if someone's diagnosed with childhood onset conduct disorder, we know what their world's going to be looking for. You're going to be incarcerated in most cases. You're going to be bumping from foster to foster. People are going to give up on you. Your self-esteem is going to be at a take. You're not going to try. You're going to be the kind of kid whose identity is I'm the trouble kid. And so why would you comply in class? That's not my job. My job is to, someone I start doing right, they look, my friends or peers look at me and, what are you gonna be good now? Like, what's this? Well, that just prompts disruptive behavior. And so that is definitely age of onset, if you will, is a big variable. Getting stuck in our role is a problem. We all have roles, right? Like right now, my role's teacher, y'all's role student. Someone could easily stand up and do this too, right? Just a little uncomfortable to switch your roles midstream. Imagine a kid needing to switch their roles or understanding they want to switch their roles. But you're in this peer group that are all kind of doing the other thing, and you're going to be the brave one to step out of that role. Well, let's just say this, it's not your peer group, it's your family, it's your cousins and brothers. Takes some maturity, takes some courage, but it also takes some opportunity, right? Sports are a great way out. You see people coming from challenging environments where they get up and they do something different, make some different decisions. And again, this isn't all about decisions. Some children and adolescents with conduct disorder develop other mental health, which could be mood, somatic, and alcohol, substance abuse, early onset psychotic disorders, etc. Long-term outlook. Real quick before I go, how does this stuff sound? How hopeful does this stuff sound?
Super.
It's kind of rough, isn't it? I'm trying to throw in some things like off what I wrote to instill some hope, because when you start talking about some of these behaviors, you could easily see how they're reinforced in the wrong direction, right? Reinforcement doesn't mean it's good. It means it's increasing likelihood it's going to happen again, right? So it's just additive. If it's in the wrong direction, additive is not good. It just strengthens the behavioral propensity for that to occur again. That's not what we want. But yeah, the picture, once we start down that trail, is hard. And we're going to talk later about like what can we do about it? I mean, it's going to take a lot to do about it. The idea of I want to find where my what did you say? Your grace was the word I was looking for. I'm sorry. Define grace. That may be something one person can do. How can you find grace in a system? You know what I mean? We start talking about, and I'm kind of a systems thinker. We've got to figure out how can we find a baby bit of grace that the system can recognize, or a baby bit of positivity that the system can recognize, so that they can start giving opportunity for more good behavior, and we can start to grow that. But inevitably in a system, let's say there's 10 components of that. If one person sees a slip and says like that, boom, it's easy for us to slip right back to where we were. If one person gives up on the positive reinforcement and or grace. So it is hard. It is very hard. Okay, again, if you need to go through this, because y'all know how bad this is, right? Y'all know this already. I want to take a little break before because we can talk about treatment options. Do y'all have a break time?
Anytime you want to give them.
What time did I start? An hour ago. Let's take like a 5-minute break. Real quick. Fair?
Yeah, sounds good.
Don't anyone needs to use the restroom or anything. What's the best part of oceans?
It's all groups for me so far, and I wasn't doing that before, so that's been interesting. Yeah.
Okay. And oceans counts as all check, makes all your tech ship stuff. Why is it Grace doing it?
Grayson's doing it.
Why she do attention?
She's not.
Right. Free money. Just because she doesn't need it.
I know.
She's like, well, she's driving, she don't need it. You could convince me I need it. It's hard to get traction.
Then it's for like memory care, which I
Oh.
you've asked about before.
Fair.
So that's been.
You know, the Gero cycle. The Gero, you have a geriatric.
Yeah, I'm at the IOP. I know they do. I haven't been to the inpatient before though. So.
Cool.
That group doing the memory. I mean, they're very happy to be there. I don't think they get in kind of like social outlets. You know, they're like pretty isolated in their homes and stuff, and that's like wonderful to see. I don't know how much like time. Yeah, like I did a group on mindfulness, and by the end there was still that.
You're all.
You know, it's a really neat concept. Yeah. But not a the terminology.
Well, who would you, what's the youngest age there? The memory program.
It varies a lot. I think they're moving away from this, but at first they were just kind of letting, like, if you want to be there, you can go there. But I think they're moving away from that, it's more like 70s.
I did a assessment on someone the other day that was 50 and having some slippage, if you will, versus inattention. Okay, we're here. So I wanted to share with you kind of a question from Raj. I had a kiddo that I worked with before we talked about children that, wow, so he was from a small town out by Abilene, so kind of a little excluded from society, if you will. he lived in a small town where, he lived in basically the county seat, right? Like where everything happens in that county. You all know what the county seat is, right? So every county has like where the city or the county courthouse is, like for Nueces County, Corpus is the county seat. We have all these other cities. Like San Patricio's county seat is Sinton. So every, et cetera. Kingsville would be for, doesn't necessarily mean it's the biggest, kind of like capitals of states, et cetera. So this kiddo, ever since he was little, crazy ADHD, like wild. I mean, and he's in a small town. His parents have done everything. I mean, single mom. He was so wild. She didn't have other kids. This was her oldest. After this one, she stopped, which means she knew at a very early age this is a lot, and she had to work and all these other things. Tried a pediatrician, got to the point where we've tried meds for years, and like we got to get you with psychiatry. There's no psychiatry in this town, so that means we've got to travel like 2 counties over to like the MHMR, which, you know, we have the luxury of having one here. If you go to all the surrounding, right, like Coastal Plains, they serve everything from like Furious, Ricardo, all the way up and all around Nueces County, all the way to Aransas Pass, Rockport. That's all one MHR. So everyone has to go to like GP or Sinton. There's a couple different outlets, but not all have the services. So they had to travel. And psychiatrist trying his kids. Now growing up, he's probably like 9. It's determined that okay, we found meds that work, but they were sure even the extended are working really short, really quick metabolism. He metabolizes the medicines very quickly, and so you had to prescribe multiple people, probably taking 3 extended release, even at Adderall. It wasn't Adderall, kind of stuff. I forget what it was. So all along, you have to understand he's getting in trouble, right? Not really breaking rules, but you know, yes, breaking rules, not getting arrested. You know, kicking people's trash cans over, throwing rocks at houses, kind of being a bully. And he's 9, right? Like a little pinner. Like, what can you do? I think when he turned 10 years old, he ran around the town square, and someone yelled at him, and like a security guard, and ran off. Well, as he ran off, he went by his house and saw a bicycle outside and grabbed the bicycle. It's gonna be a chase. Light him up, chase him down, pull him over, take him to detention. 10 years old, right? Lo and behold, he stole county judge's child's bike. First time to get arrested, wrong thing to do in a small town. So juvenile probation had informal interactions with him. But he got adjudicated to states and went to TYC. That's West Texas State School, where we had, you know, 16, 18-foot barbed wire fences. Like, it's hardcore. You're there for a minimum of 9 months. So you're 21, right? If you're length of stays, you get it, say you get your minimum, you're there 9 months. You're living in open pods because they used to have like some of the facilities used to be like adoption, or what do they call orphanage type things. So you'd have like a house person. The new facilities are all just open, restrooms on one wall, bunks on this side, and table, like you'd see a prison show, right? With the jail, they're just jails. So this kid's 10, he comes out there, and at the end of 9 months, every time you get in a fight, you end up having to have a level hearing, which can end up either falling in your case, okay, that was self-defense, okay, whatever, or you can defend yourself, or sometimes you can have a peer, like one of the older guys that had already graduated high school, and you could, some people were volunteering to be peer advocates. Typically what happens is every level 2 hearing is an extra 6 months. Right? So it just starts stacking, right? We're not playing anymore, it's real life. And so this 10-year-old gets in there, and he's the smallest kid there. He's the smallest kid across the state. And they sent him to one of the roughest facilities. They should have sent him to like a protected unit, but they didn't. And within the first week, kids are teasing him. I say kids, right? Kids are, I don't want to call them kids. They're still kids at the same time, right? But they've murdered or raped or they've done stuff, right? They're They're trying to show good behavior so they can get into the capital offender program and get and do like real work so they can get out. But not all of them have that opportunity. You gotta have someone pushing and buying for you. This little kid stole a bike, right? He didn't understand the real world. He came from a little tiny town of maybe, the county seat was maybe the size of like Port A. I mean, it's a little, he had no clue. He'd never been in school. I mean, he was there, but he never did anything there. No one, he was the kid, that's all he ever heard of. He never really tried, and he couldn't even sit still, even on 3 doses of extended release medication and mood stabilizers. So he gets there and he starts becoming a target. And it's almost like the vultures, or, when you see an animal that's deceased on the road, right? They like come, they go in and they walk and they check, and someone drives by and they all kind of back up and then they all come back. That's what happens in some of these environments, right? They're sizing up what's going on. Before you know it, someone who wants to prove themselves takes swings at them, right? Hits them, boom. Now he's walking around with a putty eye, or knocked out a tooth, 10 years old. No one's coming to visit him. No one's coming. Mom can't do it. We were probably 6 hours away from where she was. Probably 4 hours away from where she was. She's not going to make that trip. She doesn't have money and there's no place to stay. This facility was an old landing strip that just got converted at one point to an orphanage, and they quickly became one of the first of about 6 facilities across the state to work with juvenile corrections. Now they're like 16, and it's just out in the, the entertainment is to watch tumbleweed roll down IH-20. And so there's nothing out there, desert. So the kid starts getting pumped over and over and over. Kind of gets put in like the protective unit. We kept him in. So security is essentially when people do stuff, it's like the jail in the jail. And so he's spending lots of time in security, protective reasons. There's talk about people that are going to get him. His little mouth gets him in a lot of trouble, and it just goes on and on and on and on. So you start to see this evolution of like, as he's growing up, the guy was there for 3 years and he had got there right about when I got there. So in about 2 years, he's growing a little bit, he's still tiny. He's 12, and these guys, out there playing basketball, 21-year-olds from like South Houston and Oak Park, and all these, hard places. And so this kid starts to develop. Well, he's starting, what do you learn? You learn what you're in. What's he exposed to? Not the best behavior, right? People that are there for a reason, not always there to get out of there. Some are there to survive, some are there because they've got nowhere else to go. I mean, there's a lot of reasons why people are there. But his impulsivity and his lack of a filter got him to learn some of the wrong things to do, like stealing and like, being part of like trying to assaulting staff and quick tempered. And so you started to see this evolution of this little country 9-year-old to when I left there, he had already tacked on another like 4 years. One of the things that I was trying to be part of is this whole resocialization model, so to get attorneys to come in and advocate for kids. They ended up doing that, and they shaved off some time understanding some of these extenuating circumstances. But I think by the time I left, anyone would have diagnosed him with conduct disorder. Anyone would have said ODD. Anyone would have said ADHD, obviously. But that would be the kind of case, like, did that really have to go that far? Do you know what I mean? And so what are things we could have done? What are some things we're talking about? We're going to talk a little bit about treatment, but protectively, what are some things we could have done in that environment back when he was like 6? Pediatricians writing medicine. What are some things that we could have done at 6 years old? Yes. Provide mom with more support, right? Like what? What are some options? If you had access to everything, I mean, we're in my office, right? Writing everything on the board, right? All the scenarios, which I need to start typing. What are things we're putting on the board?
I don't have like exact,
Money,
yeah.
right? I mean, transportation,
Yeah, no one.
housing, food. Anything, right? What else?
So kind of like peer programs, kind of like what you had mentioned in the panel earlier.
Okay, like
which,
Jimmy said, I mean, not
again,
dry.
yeah, which again, that might be not in their community, but
It may not, but fast forward 20, 30 years. 25, 28 years now, wow, it could be now, right? Computer, phone, nowadays it's way accessible. Back then it wasn't, right? You carry around box phones. What else? What else could we have done back at 6?
I think having other adults involved in the life, so not necessarily just like mentorship through like an older child or teenager, but other adults to support him and his mother, so that they could both kind of have an outlet for some of that understanding and what they witness. And so like connections through their school, and those other adults that frequently interact with him.
Sure, okay. I like that. I like that idea of someone, you know, kind of one of the things Dr. I talked about, like a case manager, who like,
Yeah,
their job is not only to provide education and contact, monthly contact with, depending on their level, right? With the kiddo, but contact with the teacher, contact with the neighbor, contact with the security guard, contact, so everyone knows this kid and what you're likely to see is them.
I don't know if CASA was like an option back then, but, court appointed special advocates.
Something like that would be great, right? He was never, so at the time, when he was 6, never. They never did anything. Oh, you're too young. You're too young. Don't worry. Oh, no, we don't take kids that young. Kind of like what happens in behavioral hospitals here. Oh, go down to Bayview. Y'all know at all. We're just adults right now. And that's all y'all will ever be. People I've talked to. But go to Bayview and there's house. You're not 11. We're not. You're autism? Nope, nope. No, you can't come here. Where do we go? You need to go drop your kid off in the valley. The Palms Renaissance, or drive to Laurel Ridge, drop your kid off there. It's like, for how long? Well, until they're better, and we'll just call you the day you need to come pick them up. How convenient is that? So we need resources like that. So at 6, yeah, we should have been involved with work. We should have got more people to understand. What about at 9? When almost psychiatry is almost even given up. What are other things that could have been done?
you know, I kind of had this idea before the break too, but it seems like there's an existential like aspect to treating conduct disorder, like especially kind of like as they get older, kind of like with what you mentioned, that one guy that had it and just decided he's like, yo, I've had enough of this, and it sounds like it's coming from, you know, in a lot of cases, it's like a hopeless environment, right? And it sounds like trying to make something meaningful, and even that environment of being at the state school or whatever the West Texas spot was, like, it sounds like that's not a very hopeful environment, not a lot of like meaning there. So kind of like helping him develop that meaning and like that why and like what he's doing, kind of, I don't know, maybe make it more likely to have that motivation for getting out of there and not trying to add more years. That
Sure. Sure, no, I think that's helpful. I think that this would have been a good kid at 9 that we should be teaching some skills. We should be exposing, you know, anger management, impulse control, also some exposure to like, hey, this is what happens in the real world, right? This is a great scared straight kind of kid, right? Where you go and let's take you over to the next county where the boot camp is. Let's go spend a day just checking that out. Say, is this, you know, this is your future residents should you continue to engage in this behavior and not use the skills that we're teaching you. Those things sometimes work. Sometimes you take a kid into probation here and they're like, yeah, go, I got this. Like, that sounds, I can do this. It's not a threat, it's not a deterrent. So you gotta be really careful with that kind of thing. But I think kids would be pretty scared.
Yeah, I don't think the situation, like, it was like a scared straight, but then they kept him there, like, they didn't give him
Yeah.
an option to.
So, yeah, having someone, be able to advocate for him or provide legal representation and not just the county judge
this is
be
where
mad
counsel would
that you
actually
took my
be
kid's bike. It's not like the bike was broke or spray painted or, you know, he just took it because he was running from the security guards. Like, what? We were amazed because we got true conduct disorder kids, not a kid that shows up with an ADHD guy. Yes. But to understand those things can happen, I think, what are things that could have happened? Opportunities for intervention once he did arrive at EMT-YC.
I don't think anybody ever really seemed to talk to him, it was all very reactive to his actions, and there was no discussion or like concept of what are impulses. There's no education onto what might be happening in his brain, so he doesn't understand. He may not understand necessarily why all these things are happening, to give him the opportunity to make changes.
Fair.
In the situations where they would put him in security to like protect him, they're just putting him in another cell, so.
We would
seems
leave
as if-
the door open.
Oh, thank you.
Yeah, that's about
But
all we
like,
would
he's
do.
being punished for.
He would,
being
the
bullied,
security
like,
guard would go
that
sit
feels like-
there. So our security at the time was probably about half this with, 6x8 cells all around, 2 clear ones for security watch, right? We put them in small or papers. And there's offices over there, and the doors are jail doors, right? I mean, they're 14-inch steels. It's just like you would see. So whenever he would come over there, someone would be threatening to shank him, and someone would find a sharpened, instrument, or someone had jumped him, or 2 or 3 people held him down and just beat him. We'd take him over there for healing because the infirmary couldn't handle him. So it was like, okay, this is where we just created this environment for you. The door would stay open, and to the extent that we could, right, trying to like not make you feel like you're locked up. But there's times when the door got shut because you'd go up there and chat with other people and they slide notes across the, you sit just like you see in any jail movie, notes and, what they call them, flags, where they're pulling them with string across and sending notes, and that's all real. Yeah, it's like, okay, we're trying to work with you here. But the ADHD and the impulsivity and then the ODD and the breaking rules and trying to fit in became so big that it's not a lot you could do. And by the time you get there, it's really kind of interesting because we talked earlier about the well, we quickly got like that, not to mention this is the end of the road. Everyone previous. So when you think about intervention, it should have been done early, it should have been done often, it should have been done regularly. There are lots of stops along the way that didn't have to get to this, but dysfunction, disorganization, disadvantage, all of these things happened and they contributed to what was ADHD, no doubt, what grew into this giant monster, right? And for all I know, he could have been there till he was 21 and he could have maybe then gotten out under special circumstances, or he could have got transferred to TAMU-CC. I don't know, but you see the rapid escalation of something like that. And yeah, we would all hope that we would be the ones to be able to have grace. But boy, that was a handful. Just round, he was just best, every little thing. And it's sometimes hard to have patience and grace with that. It can be. And especially if the onset of it, if the pestering, now let's just say it, I don't mean to be derogatory, but sometimes that's what it felt like, the impulsivity and this unsatiated pestering. If the pestering hits you, that wave, that surge hits you too quick, it's easy just to say, raw, like stop, catch your breath, I'll be back. And that can be interpreted as rejection, and that can be interpreted as like, she's not gonna help me. And then you don't ever give that person a chance again, because those people never come back, right? Those are the teachers that put me in the other teacher's classroom, and those are the people that, that was my CPS worker that just decided to put me in a different foster home, all those things.
Like, how we're taught not to do the work for the client? So usually I can have like hope and grace, even when like the parents or like other teachers or other mental health professionals are like slowly giving up on them. But when it gets to the point that they start to give up on themselves is when I kind of like.
That's when you could have more grace then, right?
It's hard.
It's hard.
At that point, because I don't know how to like return that back to them.
So I like the idea of the recipient of services doing more work. But there are cases, and these are the kind of cases where sometimes you have to lead, you have to do more work, you have to, like Dr. I said, you've got to work on developing rapport, you've got to work on trust. You've got to, and sometimes do more work based on extenuating historic circumstances. So sometimes you have to do more work. If you're sitting in your office and someone comes in that's worried well and it's dealing with anxiety and depression, and you're giving them homework and skills and stuff to do, and they're not, that level of resistance, that may be a more applicable time to say, who needs to change, right? So I'm not a giant, not to make any judgments, but we got to do some work too. We've got to put forth the effort if we want the outcome. You do have to ask yourself, like, okay, who wants this outcome? Is this my outcome? Or is this their preferred outcome? My preferred outcome or their preferred outcome? Some people have not arrived at the position where they want what we think is right. Does that make sense? Some people don't even know what to even think about what we want, what we think is best for them. And those are hard cases. And so what do we do in some of those cases? We show them what can be, what opportunities. This would be the kind of great case, like, okay, let's just say he got out at 15. Heads up, because that would have taken getting up through the level system, moving to the kind of the honors dorm, dealing with that, sitting through a parole hearing or parole committee, and actually getting out and probably going to a halfway house. But then he gets back to his community. By then you hope that he didn't just fake it to make it, that he actually learned some things. And I'm okay with faking it to make it, because those are how you establish behavioral trends, behavioral patterns. I'm okay with that. Because then it's easier to do it because you're supposed to do it than just doing it to get to level 2. So I think that he would be a great candidate to be able to come back to his community, to be a mentor to someone else, to show them what could have been, to talk to the schools, to talk to the teachers, to share his story, right? That's lived experience. I stole a bike and got locked up for 4 years, right? It led to this, I lost my adolescence. So all of those things that I just talked about, or we just talked about, are all the things that Dr. I was talking about that can happen, that need to happen. The resources, the involvement, the continuity, all of the things. But it's also a case that shows you when those things don't happen, where things go. That makes sense? Cool. Okay, let's talk about some of these treatment things, and I'm going to try to rush. So treatment options for behavioral conduct disorders, if you will. Obviously, therapy, counseling, there's CBT, there's so many different derivatives nowadays. There's just, I could go on and on. Peer group, positive group supports, anger management strategies. The ART's been around forever, and it's great. I think I used that when I did a practicum at Nueces County, the Juvenile Detention Center, in the like 92, 93, long time ago. I'm getting old. Impulse control strategies, family therapy. I'm a way big systems and structural type thinker, very systems oriented. And I'm a firm believer that you don't take put a kid in counseling alone, expect to change that behavior and throw them back into their environment and expect that behavior to stick. Kid's going to come back with the same deficit. You're like, I taught you that, I showed you what to do. Instead, you go and you work with the whole family, and you change dynamics and roles and interactions, and you work on the reinforcement and the stick-to-itiveness of that. So that's insulated. That's one of the challenges in working with the juvenile detention and working in hospital settings. You guys can stabilize someone and you send it back to the same environment, and it's the likelihood of that changing someone is just a little bit smaller than other protective factors. Medication, obviously, medication to be effective typically requires like consistency and compliance. It's great to have a bottle of the medicine that will help you, but if you don't take it, if no one refills it for you, if there's no access to money to pay for it, right? Wow, mom just never checks the email, and our Medicaid, expired or got canceled, or this is the month when, you know, there's 5 weeks in this month and dad's child support sets us over where we don't have Medicaid for these 5 week months, you know, the 4 of them a year. We don't have services that month, right? It's like, we're just kind of stuck. So taking medicine. Then there's all sorts of community-based treatments, therapeutic schools, residential treatment centers, programs, IOPs, things of that nature. However, even with all of this stuff, it's sad to say, but by the time someone's at conduct disorder level, if you will, recidivism rates are way high, right? 35%, let's just say at the base. 35% of the people that get all the services necessary are gonna recommit a crime. That's not good, right? If 70% of them are doing that, that's horrible. Like, you can't call that, you almost reliably can't call that treatment. If 70% are re-engaging in similar behaviors. Preventative steps. I just asked the question a minute ago, so we kind of already covered this, right? What are things we could do? I mean, obviously communication, access to resources, engagement, finding out, you know, I'm not going to talk about it today, but I'm going to, you know, I will briefly, kind of like what the behavioral approach. So what are some things we could do? I don't want to go too deep into this whole thing as far as parent training, but parent training to me is teaching a couple different things. Obviously, one is motivating a parent, talking about all of this stuff. Stories about how a single intervention can start a cascade of positivity and moving in the right direction. However, a single instance can also lead to a kid 15-year in prison for stealing a bike. You know what I mean? So a single incident has to not be intended to. We have to figure out what can we do to set up systems that work. As far as parent training, teaching the nuts and bolts of parenting, skills, what to do, what not to do. Because like y'all's case, we have to presume, we don't know, but the presumption is nothing changed, so nothing changed. No one's there to teach, no one's there to model, no one's there to support, all of those sorts of things. So how to train different, I mean, there's different approaches. There's the teaching people what's just good enough, cover the basics, the good enough model, or some of the best practices. I want to touch on a couple of, I don't want to get too far into that. Working with parents, it's a fact that if you're going to work with kids, you're working with parents, period. There's no way around it. And again, it's from a family systems perspective, if you're working with anyone, you should be working with a family, right? It shouldn't necessarily be an identified patient. We work with the family. Effective parenting has been found to predict positive behavioral, social, emotional, academic adjustment, whereas the opposite typically leads to dysfunction later on. There's a lot of literature about not spending just your time training. You know, if I teach, I work with this one set of families. The difference of versus if I go and I train these people to be parent trainers who can go work with a bigger group, that notion of like greater context, greater contact, getting more of that out there would be helpful. We want to make sure that parent training is active, remediating specific skill sets to positively impact child. This book that I'm referencing here, Working with Parents and Non-Compliant Children, and it's a guide to effective-based or evidence-based parent training for practitioners and students. Great book, outlines everything that from almost like Dr. I mentioned, kind of a multimodal. It's probably not the most current version, if you will, but I really found this to be very helpful in my thinking about how to take that parking lot approach, right? Throw everything out there, the good, the bad, the ugly, the options, no, we'll never even be able to do that. I don't care, put it on the board so we can look at everything. Boom. Effective parenting is more like more adaptive socially, improved functioning, etc. There's all these theories that you could go through that would support. There have been parenting strategies built on each of these theories, if you will. Again, research, parenting attributes, style, environmental influences, etc. And then the history of parent training, again, there are better things for us to talk about. I think there's a slide. Okay, so this talks about some of the evolution of empirically supported program. I think it's, yeah, so Living with Children is a program that works with kids typically 3 to 14 that have social aggression. And you'll see kind of the evolution of some of these. So you're working with individual families and or small groups. They haven't really almost manualized they used to, which is great, but really understanding behavioral theory and lots of high level of contact with the practitioner and the family, like a whole lot of one-on-one. And it's just using basic behavioral principles, if you will, point systems, teaching data collection. You're going to quickly find that the adherence to behavioral principles in parent training is significant, right? And the more and more it evolves, we're starting to have some more experiential things, but very behavioral, applied behavioral, if you will. I think the incredible years, the basic is pretty geared towards younger kiddos. Everything from, you know, simple behavior problems increasing, well, it's more towards the littler kids, so they're more what we would call more tolerable things, more things that can easily be developmentally explained and easily adjusted. But a couple sessions, a lot of videotaping goes in this, as opposed to, so that the clinician can see it and point out when to intervene and how to intervene and give ideas on what to do and, you know, why the behavior may have occurred, if you will. Helping non-compliant children is a program that I've had some experience with when I was doing my doctoral stuff. Also the PCIT stuff I think is good, but this starts to incorporate the kiddo in the session. So it's almost started to get more like family therapy. It's more in addition to, whereas the previously videotape segments to see and to critique and teach from, this kind of brings the kiddo in to get the training so that it's more in vivo and so that the parents get support on when to intervene and how to intervene directly with your specific kiddo. Because it's sort of artificial at times when, if you're role playing or talking about, you know, something that's going on, it's like, oh no, that's when you got to do this. It's a whole lot more applicable when it's actually happening. It's live. Again, another plug for family therapy. PCIT, like I said, this is where you have direct coaching. When I was in California, and we were, one of my internships, we had annual interns, so you're there 20 hours a week for a year across each year. One was at a family institute up in a city called Pinole, and we would go in and do this sort of stuff where we'd have a bug in your ear. There's a monitor in the room. You go in there and you work with the kiddo, and you're working on typically minor types of behavior, and so. And or had a headset at times, so I'd be talking about what I'm doing with the kiddo, parents in the other room watching it on the screen. And then it's okay, I need you to go do what I did. So it wasn't as artificial as me saying, oh, mom, let's go do this. But she'd go in there, mom would put the headset on, and I'm sitting there talking her through it about what to do. Wait, stop, no, now grab this hand. So literally walking her through the interventions and then showing her how to reinforce the behavior, how to increase the likelihood of the behavior occurring in the future. So it's direct coaching. Can be single dyad teaching, a high level of skills. It's very directive. The use of technology can be a great kind of asset. Commonalities behind all of these interventions: behavioral and social learning basis, making sure that we're praising, attending, rewarding, and reducing reactivity to minor problems. When I just read that second bullet, I think about our society now and what are we doing as young parents right now? What do we see a lot of? What do y'all see in young parents?
There's a lot of pacifying.
Like this, right? Phone in hand, which means, are you attending? Are you praising? You're just happy that your kid's not interrupting your Instagram feed right now. And so when this stuff happens, and then so with respect to reducing reactivity, what happens when the mom who's been on her phone for 2 hours, or her kids have just colored the bedroom wall, walks in and sees that, she loses it, right? What? Can't believe y'all. Or you tried to, you know, she comes out of her bedroom and the kids tried to make lunch. and there's macaroni everywhere, little macaroni cups all in the microwave. We lose it, right? We lose it because we didn't supervise well. These programs push the opposite. Clear demands, immediate consequences, punishment. Consequences include punishments, right? Punishment designed to decrease the likelihood of a behavior occurring. It's not what we want to have to do, but there are times when punishment's way appropriate. We want to try to use reinforcement, whether positive or negative, but sometimes we have to exercise other options. And making sure that contingencies are set up so that we have a plan. We need a plan if you're going to be proactive and preventative of some behaviors, and we know that this path, if you will, that starts here, continues to grow and escalate with intensity. We've got to have a plan to cut it off, to be proactive and preventative, and it's got to be a plan, not something you're just winging.
Are these programs accessible to those who need it most?
So the answer is yes. In communities that have good programming. Does that make sense? So there's all sorts of, yes, if I went down to University of Massachusetts, anyone that's in poverty, there's graduate students there that are really, if you're in a university setting, there's a lot of stuff that takes place here. If I come down to Kingsville, no. So it's going to be places, nothing against Kingsville. It's going to be places that are working on social justice, they're working on criminal justice, they're working on social work, psychology, counseling programs that are university-based. Everyone in there would have access to free programming. There are some practices that do things like this. Is it enough? No, we're looking still at 4%. Not that this in and alone stops conduct disorder, right? There's still brain damage, still has other things, but can this help? Of course. So instruction, modeling, things of that nature across programs. These are a list of other sorts of programming. There are people in town right now that are using Triple P pretty commonly. I mean, I know that there's one individual that it's about all he does. He's just doing it predominantly for a pediatric group here in town. So there are, I mean, it is around. Yeah, these are some of the most popular, and the beautiful thing about this is like manualized workshops and seminars are available, online conferences. Getting training in some of these things is not hard. Having this stuff, we talked about what would you be doing as a novice therapist? I would be learning something like this, because it would be tools that I'm putting in my tool, right? So that when I go out and I approach any given population, I make the decision of which tool to use. And trying to intervene early, these sorts of things. Anyone that presents with, childhood or adolescence type disorders, you're talking to parents. So the parents are the ones that want it. So let's teach the parents how to interact with the kiddos, so to speak. And then I get into this whole idea of behavior analysis, which I'm probably not going to do to y'all, because I'm a giant fan of ABA, but it gets way technical, and I can send it to just how to teach, how to reinforce the teaching, how to set up situations, behavioral skills, training, etc. Typically, when you're going to work towards teaching behavioral skills, like we talked about, that kiddo should have had like at 6 or 9, how to teach them the skills. You want to make sure you provide good instruction, right? That you want someone to be there to model that type of behavior, that you have opportunities to practice, and then you get some feedback. This would be the case whether I was teaching a kiddo, whether I was teaching a parent, whether I was, no matter what, you've got to hear about it. What are we going to be doing? How are we going to do it? Got to see a model, practice it. Then you need to be practicing it with someone and teaching them so that they've got it. They need feedback. Feedback is reinforcing, so that increases the likelihood of that behavior occurring. This is how, let me ask a teacher. Is that the way that we're supposed to teach?
Yeah.
We
do, you do. So gradual release.
Yes, let me show you. Let's do it together. You got it.
And I would say that regarding ABA, in other behavioral models, you don't have enough of that, modeling and practice within the classroom. And so then you have those, SPED instructors or case managers explaining it to you, giving you the papers, whatever, this is a contract, this is this. But then there's not, the system's so overworked that there's not enough opportunity for other people to like put it in action for you to learn from.
True, I fully agree. I think that if you went into any school district in this area, there are behavioral specialists, but that does not mean that they've been trained in true behavioral stuff, right? Like the number of BCBAs in this area is raw. They're not at every school district. They contract with school districts to go write FBAs or go do things like this. But even then, I've got like 3 pending, 2 with Corpus and 1 with Cal Allen to go out and do an FBA. And I tell them, okay, this is what we're gonna do, the whole thing. I'm gonna observe, I'm gonna go, interview different teachers, different times a day. They're gonna have me and, one of my LPAs, I'm gonna go and do it separately. So we're not, in case we get noticed, it's not just one of us. We all have different views. We're gonna find out using tools, what's the true function of the behavior. We're gonna write up an FBA, then we're gonna turn it into a behavior plan. And I expect to come and teach those interventions to every one of your staff that will have interaction with this kiddo. And then everyone's going to collect data because on a monthly basis, I need to compare the data. I want you to collect data on the incidence of behavior as well as the incidence of teaching. And I need to see those numbers cross, right? As we're teaching more, the numbers need to be coming down. And school districts will respond to me like, wow, what's that going to cost? Yeah, and then we're having quarterly meetings to look at, because you look at a snapshot of data is another thing. I want to see a trend because that would indicate whether or not we're going to be then modifying and changing the intervention and or, the environment. What do we need to do differently? And they'll look at me and like, can you just write a plan and we'll carry it out? It's like, well, sure. I mean, it's not going to work. It could work. We could get lucky, but it doesn't allow you to continue to evolve and modify while the environment and the kiddo continue to evolve and modify. So it's, a behavior plan needs to adopt all of those. I don't know that, no offense to anyone, but I don't know the school districts or really have people that are trained to do that.
No, you have a lot of,
They're more worried about pay.
we have a lot of SPED professionals who, there's usually like
And a lot of seminars.
a handful of those who really, care about and emphasize behavioral needs in students. And you have like those units or classrooms where those students can go and they're trying to apply those things, but it's overwhelmed. And so then you have you see within the classrooms that a lot of those instructors, those teachers cannot fully attend to the needs in that way. And so they're like, okay, we'll go to SI. And it's like, that's not gonna.
Sure. Right, that's not that's the plan doesn't say go to SI. And then you also have things like, okay, so like train everyone, I come and I do this kind of model, I show them, or I wrote a behavior plan, okay. Boom, we're going to explain what's going on. This is a lesson. This is what we need to look at, the skills to be taught. Here, let me show you, just like you did, right? Tell you, show you, or I do, we do. So this is like I do, I'm showing it. First, I'm going to tell you about what we're going to do. Then I'm going to show you how to do it, right? Set it up, demonstrate the skill, show the skill, then practice it. This is kind of the we do. Let me show you what's going on, how to do it, what we need to be doing, why we need to do it. Then some feedback, right? The next step, if you will, is then you do, and not only do you do it up to a point of mastery, but then I'm coming back in a week, show me you're still doing it, right? So I make sure that the behavior is established, make sure that everyone's still doing it the same way, and that the data is being collected every single day, all of those sorts of things, because if you don't, then you're making up data at the end of the month, and that's what a lot of people do. And then so the authenticity and the accuracy is skewed, and so why even do it? But this model works for providing feedback. Obviously, we've got to find ways to enhance, motivation, if you will, because there are those people that drop their kid off, right, at different clinics. Wouldn't even name any, but they'll drop them off and they'll be back, right? And it's like, oh wait, do you want to hear from me? Nope, I'll be back to get my kid. And they pick their kid up and like, okay, cool, we'll see you next week. wait, there's some clinics that have that as a model, right? Where we don't do a lot of family stuff. We'll consult with you in 6 weeks. So convincing the parent that they've got to be involved is difficult. Also making sure that we're talking to people, like Dr. I mentioned, it's like, I gotta make sure I'm using words that I can communicate with, right? If I'm talking my behavioral terminology, it's not really gonna help anybody. I need to be able to break it down and know my audience, and know what their motivations are, etc. Barriers, all of these sorts of things. Treatment adherence, talked about building rapport, using incentives, using technology, flexibility, cultural issues. Could go past all of that. And then it just goes into kind of a framework. We don't need to do that. Just gets into a bunch of behavioral stuff, which is where everyone glossed over last time. Monitoring, all the behavioral things. This is really just using applied behavior analysis. Cool. So, what does all that sound like to you? What did y'all take away from that discussion? You feel like you understand behavioral disorders, conduct disorders? Do you feel like you understand? So, I mean, you can always read that stuff, but do you feel like you understand the prevalence of it? The potential path, things that can be done, ways to do those. That's the hard part. It's hard when we know what to do, but it's bigger than just us. That's the hardest pill to swallow. It's like, I see this wave coming, but I alone can't stop it, right? I may slow it down. I may be able to divert it. If that's where you are and you see where it could go, then what do we need to be doing? Yes, we can do this parent stuff. We can use behavioral principles if we catch it early. But what do we do when we're in the middle of it? What are things that you guys will be able to do?
Yeah, I don't know if this answers that question, but I guess like the takeaway from me is that I guess this is like a really good topic for integrative care, just the whole teams-based approach, and then even definitely, of course, like getting, the family involved, right? Because like you could execute everything perfectly in session one-on-one with this individual, but again, like as soon as they go back in their environment.
So I love what you just said, and this is so applicable to y'all, Tex-CHIP stuff, right? Y'all are learning the value of integrative care, right? You're learning to work with other professionals in alternate, if you will, type settings. I hope that we see a day when they're not alternated, they're part of. I'd love to have, a whole treatment team, a model like MHID has, a model like the hospital has, where, boom, psychologist is there, the counselor's there, social worker's there. You come in and you're there for, like the what is it, the Betty White, place where you walk out with everything, the best treatment center in the world kind of thing. Managers, and there's that kind of thing would be beautiful. It's hard to replicate, but when you think about integrated care, we don't always think about family. We don't, and we don't always think about the implications of someone's, like in the hospital. You can change your behavior, you can change your role, you can change your persona, you can change your mindset. But if you return right back to the same thing, how long is that all going to stay in place, right? If they weren't taught that you're changing and they weren't ready to change, it's like, everyone's got to be on the same page to evoke big change. Things y'all can do now at this point are, number one, be aware of it, be educated, be educating the people you work with, and be advocates for it, and be pushing to communicate, and be pushing. I had a meeting with the Superior is a firm that is one of our Medicaid management companies, right? And I met with their regional directors. She runs behavioral health for basically Harris County to Laredo and South. And she's talking to us. She came and presented to our work group probably April. And then I had another conversation with her just recently, and she's really pushing the idea of collaboration. And that really, most of the managed healthcares are expecting the provider to be reaching out to other providers. And I'm asking, okay, so where's the code, the billing code for me to call the pediatrician, the psychiatrist, and the teacher and all this? So, well, you gotta be notating it, but there's no billing code. Like, well, how do y'all, if I'm not getting paid for it, how does that happen, right? So there are even some systemic challenges. It would be great for me to be able to pick up the phone and, hey, all I'm gonna do today is call psychiatrist and go through the list, be a home run, right? So I can get where I'm gonna call before I meet with Johnny tomorrow, I've looked at my schedule, let me call his teacher and get a status, his pediatrician and get a status, what's going on? That'd be a home run. Does it happen? No, I'm hearing what Johnny's mom says. And hopefully she's got some good answers. If not, I'm going in dark, right? And then I gotta evaluate, so what is she telling me and why? What's her motivation? There's a lot of things that go into it. The idea of integration and collaboration is beautiful. It's what it's gonna take. There's gotta be more greater systems to be able to make that work more efficiently. Other topics on what y'all can do, or what you're thinking.
I guess that made me think about like familial resistance to change. So not even just on the kids' end, but like acknowledging that a child may have these difficulties, recognizing it in someone else, but not recognizing it in themselves, and recognizing what led to those kinds of positions because of shame, because of cultural perspectives, those kinds of things. And so you can fix them, but I'm going to do what I'm going to do. And so that you see that a lot within my experience, like within the school system and stuff. And just like in family, like people that I know, my culture, there's a huge familial resistance to change because it's calling into question how that person was raised and all of those things. And so then you're not getting that extended family support as well.
True, I think that, yes, fully positive of that. And I don't know that everyone understands that, but it is important. It's also, I mean, just like I mentioned, it's like, send someone back to their environment where no one else wants to change or support their change. But that's work. But wait, I had someone the other day that I done an intake for an evaluation like in February, and they showed up bringing their forms to me last week, and I was like, hey, so how have we been? Like, when'd you fill out these forms? Oh, back in February. Like, yeah, we're gonna have to start over. That's not where we are anymore. Well, no, he's still doing the same thing. I need a snapshot of the teacher's view about like now. And she's like, it could be 9 more months. I could get depressed again, all right, and all these things that got in a car accident, and I got sick, and COVID, and boom, 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 and then I just didn't have time, and he's in trouble, and life happens too, and things can easily get in the way, and people can be more in their place when they need to be contemplating how to be in a different place for others. A whole lot to it. It would be beautiful if everything was just in a box right there for you where, oh, I need that. I'm gonna go get it off the shelf. Go put it back on there. Beautiful. Y'all's training would be. But it's not. But there's a whole lot to learn from it, and a whole lot to learn from experience, and a whole lot to learn from exposure to a lot of different things. So get a lot of broad exposure, do the integration thing. The integration piece is big. That's the direction I'd say that our fields are going into. It better be if we want to truly have a bigger impact. Yeah, I think if you look at some big models across the states, and even in other countries, the programs are much more collaborative, and to the point where you see even some private practices that have all of those things. It's hard to remain small, but if you're checking in with obviously, let's say you're going to your appointment, and the first thing you do, blood pressure, height, weight, anything new, touching base with your case manager really quick, what's up, what's going on. These are some things that I'm going to send you this link to get on to update this. then you go walk in, you see your psychiatrist, and then boom, you're with your counselor. Those practices exist, and do great work.
Do you think that like the access to universal healthcare in other places contributes to like the prevalence of these integrated systems?
So I would hope that, so that's a way loaded question that I'm not qualified to answer. However, I would hope that in the spirit of unified types of healthcare, universal healthcare, that would be the case. I would like to think that it wasn't financially driven. I'd like to think that. I'd like to think that, yeah, there are countries that are doing things, stepping outside the box. But I think that it also requires a great deal of funding, and I think some of the challenges are, big entities that have the ability to lobby to keep things the same. I think that would be a safe thing to say. A great example, my sister works for a lobbyist, and my daughter, who just graduated from not this school, but the other one, is working on her PhD now, and in psychology. She got asked by my sister that she wanted to do some side job, some work. So she's working with the Texas Medical Association on a specific project to block psychologists from having prescription rights. And it's really kind of the funniest thing, right? This 23-year-old kid that aspires to be a psychologist. And so she's asking these lobbyists, these suits, and representative from AMA coming down that she meets with, and is trying to, she's asking hard questions like, well, how many of y'all go out to the rural areas? I mean, like, who serves them? And the answers aren't really there, and they chuckle and they but that's something new, and she's getting great experience, and they love her, and it's all good. She's not working for them per se, and that's not her direction. She's supposed to be working the other way, crossing over, which is why I wore this shirt today. But yeah, we've got to be able to ask hard questions if we want systems to change. We've got to be able to advocate for for service delivery. If we don't do that, then what are we really doing? We're accepting, we're promoting what's being done now. By doing nothing, you're supporting the current direction, if you will. And that to me is, it's just not it's not gonna promote where we need to get, where we want to get. Not an answer, but
No,
I talked around it.
interesting. Sorry.
Do you have an answer to that? It's a hard one. That's Canadians. Yeah, fair, okay. I don't know, but it would be nice to know, like, I believe, like I said, I believe that the collaboration and integration is what's driving that, and the benefits and the research behind it. There's a lot of things that go on.
It seems like there's a lot of growing pains in that.
There have to,
Yeah.
anything worth
So,
having,
like,
it's gonna
people
instill some pain.
Are willing,
Some
there's
struggle.
more willingness now.
Yes. I think there are also, one could argue that there are also some professions that don't like other professions and feel like they're stepping on their toes, and sometimes that, the big fish swallowing the little fish happens too. A lot of stuff out there that you guys are good to think about. Your project at hand now is to be a good therapist.
Like, I don't know, finish off with like instilling some hope.
Oh, no, so I will say that.
So, I don't know, it feels like the whole world is against us, and I'm trying to.
No, I want you to be.
You can
So,
fight.
okay, so that kiddo, in my example, didn't have to get there, right? Didn't have to get there, and it could have been any one of you guys that could have been there at age 6 and or at age 9 and or at, adjudication. That could have been all it could have taken to change this kiddo's entire trajectory. I may not have said it, but that was that was the implication for bringing it up is any one of y'all, trained or untrained, could have done that. Anyone out there could have had the voice to say the right thing at the right time the second that window opened, right? You just have to have someone there to do it. And it could have not even been to the kiddo. It could have been to his mom. It could have been to the teacher. It could have been to the judge. It could have been to anyone. So someone's got to be continually advocating and communicating and saying these things, even when they're frustrated and they feel like it's right? Is that Charlie Brown? Yeah. Anyone could have done that because eventually that window could open and it could be heard. And if it's heard like, rah, you suck, and then you're never going to be anything, and you can't do this, and get out of here. If that's the first message that's heard when the window's open, that's you're starting from below ground zero. So again, it just takes one of y'all. It only takes one of y'all to start advocating for all of this, for all of these changes. It only takes one of y'all to push for integration. It only takes one of y'all to do any of these things. More of y'all that do it, the more likely it will have a positive outcome. Right? Do y'all have like a counselor's advocacy group here? Well, are y'all involved in it?
Well, there's like Nice Thing Toyota, right? We also have now, the Gulf Coast Counseling Association is starting to emerge back again.
They are.
Yeah.
I heard that.
So now, they're starting to, I think Bailey's involved. Dr. Bailey Cramer is, I think the president-elect, right? So we're starting to see, I think, our community come together through a lot of these organizations now.
Yeah, so I think that based on that, I think they're having Bayview has a monthly, what they call it, breakfast cereal kind of thing, and they do presentations that are free. You even get CEUs, not that you need them right now, but I think theirs is coming up in a week or two. If you go to Bayview's site, that it'll be like in their gymnasium, and GCCA is doing like hey, we're getting back into this event. You were pretty active with GCC.
I was president.
But then you went out there and right, that was RGB, the Kingsville, and now you're back.
Yeah.
Good. I will tell her in a minute to go. So I'd say that's going to be a great avenue of support and intervention. I would say that Bailey also does a group for, I think it's called Corpus Christi Psychotherapy Support Group, where they get together once a month there at the office and just kind of, collaborate, share ideas, vent, talk about new stuff, all of just that sort of thing. To the extent that those things happen, those are grassroots opportunities to get stuff to change, to get our community to start thinking differently. You never know, a conversation could happen where someone has an opportunity and has space or has, is going to have the ear of someone and things boom, 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 boom can go. But if nothing's said, if the window's just shut, that's what we are. So you got to get active in the community. You got to get to do these things. It's important. Other questions? Was this helpful at all? Better than me lecturing?
Yes.
No, y'all were here before. Is it better for y'all?
It was wonderful. We really appreciate it. Let's give him a round of applause.
Thank y'all for participating. Beautiful. All right. This is yours. Don't leave it here.
So we're all set. So we're probably gonna then end a little early. We're gonna end early today. So y'all are able to go get some lunch, enjoy yourselves. And we'll see you at our next training.
November 16th. If you guys have a chance, if you want, we have a workshop. Me, Lena, and two of our other board members have a workshop that will literally be in this room, Friday at 6 to 8. TAMU-CC will be here, just talk if you have any questions. And then Saturday, we have the supervisor and site fair. So you can walk away with the supervisor and job and travel. Any questions? So I didn't work at the workshop, so it's basically talking about navigating my graduation.
Bye, guys. Thank you.
Thank you.
Yes, enjoy Thanksgiving. Eat good.
Navigating like after graduation, so, just kind of like taking our experiences, putting it together, and helping people. Because when we graduate and then they're kind of stuck waiting on like, to eat or how to find a supervisor, or kind of like feeling stuck, you know, we still have questions of applying for your applications or and aid, whether that's LMT or LMC, that's literally impossible. And nobody teaches you about that when you're in the program, you just go, and then you're stuck mode, and you're waiting, here's that thing. So you're trying to find a job, you can't get a job, then you have to have your aid. So that's what we're gonna talk about. And then NBCC, reached out to them. They're supposed to be there, so you can ask them questions about the NCE, the NCC credential, or even cost questions. But I'm definitely harassing them this week, so that they can be here, and then we're pleased you guys.
For the shop, because you can hire my son, I come a little late.
So we're NBCC, we're leaving the last hour for, but we're gonna do our presentation within the first hour. So we're doing.
Please take some, of the snacks we have. Feel free to grab a water.